Yeah, we are live.
Okay, we can start.
So, Dr. Sangeet sir, would you like to welcome everybody?
Good morning, all. On behalf of Bombay Orthopedic Society, I welcome you all for the last academic event before our annual conference, which will be held in last week of this month. Our convener, Dr. Sudhir Warrior and Hemant Patankar. We are lucky to have Sudhir with us. Either he is busy with attending the Sportsman or in Davos. And the other faculty, another fantastic hand surgeon who's reachable and has simple ways to treat so many hand problems is Dr. Hemant Patankar. Both of them are great faculties. Apart from them, we have two local boys, Dr. Randy Bidra from JJ Hospital, who has migrated to Gold Coast, Australia, a blue-eyed boy of Dr. J.C. Tarapurwala, and Dr. Chaitanya Mudgal, who has migrated to Boston. He is from Sion, if I'm not wrong, and a blue-eyed boy of Dr. S.S. Vengsarkar. Because we often hear your stories used to hear your stories from both these stalwarts. And besides that, we have our local BOS members, Pankaj, Anil Bhatia, Dr. Samir Kumta, and other guest faculties for this event today. So with this, we can start with the session.
Yeah. So on behalf of Bombay Orthopedic Society, again, my pleasure. And thank you, Mr. President, sir, for such a warm introduction of all the conveners and the faculty. As you all know, the theme of the Master Series throughout the year has been practice changing ideas. And hand surgery, I think, is one of the most ancient sciences known in India. We have seen a complete turnabout in the way it is being approached. Some things which were sounding only mythical, like hand transplants, are now a reality. So you can imagine the radical quantum leap of changes that have happened in this field. And who better to convene these and bring these ideas to us other than Dr. Warrior and Dr. Hemant Patankar, who are complete maestros in their field, very well versed with and kind of fine-tuned with all the complex interactions of the hand. Without much ado, I hand over the proceedings to Dr. Sudhir Warrior to take you through the first session.
Thank you, Rujuta, and thanks, Sangeet. Hemant and I, first of all, are very honored to convene this meeting, and we really enjoyed working on it and bringing together a faculty of really great names, and all of it with some connection to Mumbai, so that it fits in not only with the team, but also with the fact that Bombay Orthopedic Society should be proud of all of the faculty that we are putting on show today. Game changers, from the time when we joined hand surgery with Dr. B.V. Joshi, Hemant and I in 1988, 1989, we did a lot of work that was fascinating back then. And many times we were extremely happy. And then there were times when we were really looking for better solutions. Over the years, these solutions crept into our practice and became things that we use every day. But the one thing that hasn't changed at all is the fact that the basic principles of hand surgery were probably better respected then than today when I look at people doing things with hand surgery. So we must understand that while we must adapt to a lot of changes, we mustn't forget the basics. And through this session today, I think we would like to bring out what has fascinated us and made us change our practice, and things that we all desire to change too, sometimes not so easily. And for some of us, probably we are a little late in all of this, but those are the things that we'll try to bring across to you. Hemant, do you want to add anything else?
No, I absolutely agree with you. Tissue respect is the thing which should not and cannot change in hand surgery. And knowledge of splints, that is very important to achieve a good result in the hand.
Right. So we'll start the session on the dot of 9:05 with our first talk by Hemant Patankar. And the idea is that he's going to talk about unstable fractures, where you need to fix fractures and how you can look at fixing these fractures with newer implants. Hemant.
Thank you. Can you see?
Yes, sir.
Am I seen?
Yes.
Yeah. So the idea of talking on game changers in hand surgery is, I think, very good. And what other game changers can be there in hand surgery, apart from mini screws and plates, especially for hand fractures? Mind you, only these implants are not adequate. We must have precise instrumentation for executing these implants. However, when new screws and plates are being available, we find newer indications to treat hand fractures, which were initially either treated only by plaster or just given up, or by just say K-wires here and there, or even external fixators. So this is a case, these are the two examples which I'm giving of a mallet finger and a jersey finger, which I think have benefited the most by using the mini screws. Now you can see here that the DIP joint is subluxated here in this case, where there is a 60% involvement of the joint. So there is no point in thinking of using a splint in this case. And you can see that this fracture has been fixed with 1.8 millimeter K-wire and one interfrac screw of 1 millimeter. And you can see a very excellent restoration of the joint. And this is the function. Just to, I would say, reiterate that this fixation was not a fluke. Sorry. Reiterate that this was not a fluke. I'll show another. This is a way we fix it. I take a dorsal H incision, identify the fracture site here, and then fix it like this. Well, I use a 0.8 millimeter K-wire inserted through with a drill, and in the same track of the K-wire, I insert the screw. This is another example where, again, the distal phalanx has hinged at the fracture site. So this fracture also cannot be treated with a splint. You can see the hinging, and this was treated with a 1 millimeter screw after close reduction. And that's the result. Another case, another series of injuries which benefit the most with this mini screw fixation is the jersey finger injury, where you can see a huge fragment here. We are lucky that there is a fragment is so huge. So here also, these fractures necessarily have to be treated with open reduction. These are treated like a flexor tendon injury zone 1, and the fracture is identified. The fragment is put back, and if you can get a 1.3 millimeter screw which has got a good head, then that's the best for these cases. All these injuries will eventually behave like a zone 1 flexor tendon injury. So they will all have a flexor contracture, and this is treated by gradual stretching with these splints after 6 weeks. And you will be rewarded with a very good result. This is another case. Now, very important to know that in jersey finger injuries, that you must take a dead lateral view and be sure that there is no additional fracture in this case, like what was there in this case. After we opened it and we tried to put a screw, I realized that there is a complete fracture here. And so first, this fracture was stabilized with 2.8 millimeter K wires, and then 2 screws are inserted on either side of that, like this. And eventually these K wires were removed with such a good result. and that's the function. So jersey finger injuries are a flexor tendon avulsions and should be treated with like a zone 1 flexor tendon repair. This is a case of a road traffic accident, and he had a very severe displaced fracture. Now it would be probably unthinkable of fixing these fractures with K wires or even external fixator. So this was the same wound was re-explored and the fracture was fixed from the volar aspect with such a good result. And obviously because of the injury, he developed a linear contracture here. So this was also stretched out with a splint after 6 weeks and gave a very good, reasonably good result. This is a fracture of the proximal base of the thumb of the proximal phalanx. You can see an intra-articular element here. So here, through a dorsal incision, I first reduced the articular surface and fixed it with a 1 millimeter screw, and then the fracture of the shaft was fixed with 2 additional screws. And this gave a very good result. This was a patient who had a rotational deformity following a road traffic accident, and there was an absolute inability to move this ring finger. And she had a split depressed fracture of the proximal phalanx base here. Now here only screws or only an implant will not suffice. This has to be treated with all the principles of a intra-articular fracture, and that is you have to reduce the joint through a dorsal incision. You have to fill up the space created or void created by the accident with a corticocancellous graft. In this case, I have taken it from the distal radius. And then you can see that the 2 cortical pieces were fixed with these 2 screws. The advantage of this 1 millimeter screw is that they are absolutely low profile, and there is a very less chance of the extensor tendons getting stuck up there. That's the fixation. You can see a good alignment of the articular surface, and that's the 9-year post-op result in this case. This is a pathological fracture. There was a tumor here which cracked open, and there was an intra-articular fracture here. So now here also, through a dorsal incision, I approached the fracture site and curated of the fracture, and then the articular surface was reduced and stabilized temporarily with a K wire. Eventually a screw was inserted here. This defect was filled up with a graft, and then the whole construct was buttressed with a locking plate here. That's the fixation that you can see. This fracture eventually healed, and this is the 1-year post-op result after fixation. This was a case who presented with a malunited fracture of the proximal end of the thumb metacarpal. A very severe malunion. I think this justifies correction and fixation. This was fixed after open reduction with a locking plate here, and that went on to give a very good result. This is a case of a blunt injury to the proximal phalanx of the thumb. There was no tendon injury, there was no neurovascular injury in this case. And this was treated initially with interfac screw fixation, and then the whole phalanx was, the whole construct was neutralized with this locking plate. That's the fixation. So you can see that the advent of mini screws and mini plates, even the locking plates, have really, I would say, changed our outlook, and we can treat these injuries better. Initially, I would say that this about 10, 20 years ago, 10, 15 years ago, we would have just cast him to an external fixator, and patient would have to live with whatever deformity was resulting in that. And this is the early post-operative result. This was a case of a pedestal fan injury where you can see a comminuted compound fracture of the middle phalanx there was an amputation at the same time of the ring finger. And this was treated with a bone graft, a H plate, and one interfrac screw here. A temporary K-wire was also needed to stabilize it while before the plating. So this was just kept as it is. Eventually, the K-wire was removed after fracture healing, and the patient started mobilizing. But I realized that he is developing an extensor contracture or extensor tendon adhesions at the fracture site. So I removed the plate, did an extensor tenolysis, and this went on to give a very good result. This was a patient who had a self-inflicted injury due to an electrical cutter, and he had a tendon injury. He had a compound fracture of the 5th metacarpal. This was the preoperative X-ray. This was the fracture site. This was the bone loss. So we tried to align these bones, but they were not, because of the loss, it is absolutely unstable. So I took a corticocancellous graft from the olecranon and inserted it at the fracture site, and then temporarily stabilized it with a K-wire. But then I realized that this K-wire also is giving a good stability. So I just kept it and cut it flush and inserted a locking plate and stabilized this construct. And of course, I repaired the extensor tendons. That is the 4 months post-operative result. And that is the function at the end of 1 year. I thank you all for your attention.
Thank you, Hemant. That was an absolute, it seems like when we trained, this would have been like a fantasy. To think that small fragments of bone could actually be harnessed and held together stably enough to start early mobilization. That's really fantastic. And we will now move on to the next talk. This is another game changer in the making as far as we are concerned in India because of the implant support that we still require. But Chaitanya Mudgal, who heads the hand surgery department in Boston in Mass General, is spearheading this invention, and I will play his video in just a second.
Atankar sir, if you can go to YouTube and answer the questions which have come. Madam has given you a link to the YouTube channel.
Yeah, I've even typed them in the chat box, but I think for now we'll do all the talks together and then have questions for everyone.
Good evening, everyone. Greetings from Boston. I'm honored to be a part of this meeting. And I'm going to be talking to you about intermedullary headless screw fixation of metacarpal fractures. But first, let's lay the backdrop for how this technique came about. This is a paper that I published many years ago. And what you're going to notice is this was a paper that largely dealt with plate fixation of metacarpal fractures, which is still a wonderful technique. But in this paper, we found that we needed to remove plates, both of which had been placed very distally and caused impedance of MP joint flexion. So this is another patient who was sent to me having had this metacarpal fracture fixed someplace else. Now, what you're going to notice in these radiographs is that that plate appears to be extremely distal on the index metacarpal head. Not surprisingly, this was his function. And you notice he has significant lack of MP flexion because there was interference with the extensor mechanism and capsular tightness. Therefore, not surprisingly, he required removal of his hardware and an MP capsulectomy, and he went on to have a reasonable outcome. So basically, we understand that there are certain fractures of the metacarpal which are not really suitable for plating because they are very distal. And we have seen what could happen if they were plated. So then the question you have to ask yourself is, if you don't plate them, what else can you do? And that was the problem or the conundrum that I was faced with when I saw this patient many years ago. A subcapital fracture of the fifth metacarpal with very little bone distally. And that led me to the invention of this technique of intramedullary headless screw fixation of metacarpal fractures. So over the next several minutes, we are going to look at indications for this technique. We are going to learn the steps of this technique, and we are going to evaluate the outcomes of this technique. So what are the challenges of subcapital metacarpal fractures? Well, firstly, like you just saw, there's minimal amount of bone which is available for stable fixation. The metaphyseal bone tends to be largely softer, and the hardware purchase may not be adequate. If there is comminution, then it's even worse. And as you just saw, the hardware can be quite prominent, causing stiffness. And if you're injudicious in handling of the metacarpal head, then it can lead to avascular necrosis of the head. What are the advantages in this situation of using an intramedullary screw? Well, it gives you fixation in the subchondral bone. It's a load-sharing device as opposed to a load-bearing device. The threads offer you rotational stability distally in the metacarpal head and proximally in the isthmus. It is stable enough that it allows you early motion, and it's minimally invasive. And finally, the metacarpal head size is pretty much similar to the scaphoid. But before you embark on this technique, you have to be cognizant of metacarpal anatomy. And what do I mean by that? You have to remember that the metacarpals have a longitudinal arch, and the dorsal third of the metacarpal head lines up with the medullary canal. You also have to remember that the narrow isthmus allows you to achieve purchase proximally, giving you stable fixation. Now, all metacarpal medullary canals are not the same. In my experience, I've found that metacarpals 2, 3, and 5 largely accept a 3 millimeter screw, but the metacarpal 4 tends to be very gracile, and it usually takes a smaller screw, usually a 2.4 millimeter in my experience. So this is what we did when I first invented this technique. This was the first case report in 2010. And the one thing I have really emphasized that preoperative templating of the medullary canal is an absolutely critical step. So here is that 54-year-old librarian that we saw, and very little subcapital bone available for fixation. So this was an ideal situation to fix it with an intramedullary headless screw. And you can see for the fourth metacarpal, we use standard fixation techniques. My thinking has evolved a little bit more, and I'll talk more about this in the next few minutes. And there she is at about 6 or 7 weeks. She was unable to have any rehabilitation because of some social commitments with her family. And when I saw her 9 years later for a different problem, this was her outcome. So it was durable, she had no pain, and more important, radiographically, you can see that the joint space is well maintained and there is not any significant degree of degeneration. She had no pain whatsoever, and in fact, did not complain of this at all. Let's look at the technique in a stepwise manner. Here's someone who came to me with an obviously displaced distal neck shaft fracture with malrotation. So we did our preoperative templating very meticulously. We measured the size of the isthmus, which is critical. And we did the close reduction. The entire procedure is done with the mini C-arm image intensification. So we did a close reduction using the JAS maneuver. You make a small incision over the MP joint. You split the extensor, and I do a capsulotomy, or sometimes you can do a small local capsulectomy also. The really critical feature is that your starting point of the guide wire must be in the dorsal 1/3 of the metacarpal head, as you can see here. So the guide wire is being placed, and as it is drilled across the fracture site, you do the JAS maneuver to reduce the fracture. The guide wire then acts to hold the reduction. And once you confirm in orthogonal views that the guide wire is indeed intramedullary and in the right starting point, then you drill it across the CMC joint so that it doesn't back out when you're using the drill, as shown here. So you drill all the way past the isthmus, and you use the longest screw possible that will engage the isthmus after measuring it. The screw is placed by hand, never on power. And now what you're going to notice is my left hand is holding the joint in flexion, but more importantly, as the trailing threads of the screw engage the head, it will exert an external rotation torque. And you do not want that to happen in causing malrotation at the fracture site. So in effect, I'm holding the finger from rotating externally as I'm tightening the screw, as it engages the metacarpal head. And here it is, you can see that the screw is subchondral, the articular defect is quite small, and more importantly, we have also achieved nice engagement in the isthmus. These are the formal postoperative radiographs, and at about 6 weeks, she has superb function with no other problem. This can be utilized for multiple metacarpal neck fractures also, and here's someone who was fixed in a similar fashion with 2 headless screws with excellent outcome. And I have expanded this technique to even utilize it in situations where there is dysvascularity of the hand with multiple metacarpal fractures in this person who had an unfortunate meeting with a wood splitter. Now, this was the radiograph on presentation. So the headless screw technique allowed us to achieve skeletal stabilization very, very quickly and allowed us to get on with the more important work of reperfusing the hand. So here he is, at about 6 or 7 weeks. We sacrificed the small finger in an effort to save the other digits, and he has recovered good function, and he went on to achieve even better function as time went by. Now, as with any new technique, there's bound to be criticisms, and I respect those. The first criticism is, how can you make a hole in the articular cartilage? Oh my God, it's blasphemy, it's sacrilege. And there's going to be arthritic change. It may even cause compression and shortening, and it doesn't give you lack of rotational control. But in defense, what I would say is that you have to remember that the metacarpal head size, as I said before, is very similar to the proximal pole of the scaphoid, or the proximal half of the scaphoid. Now you have screw threads proximally and distally, and those give you rotary control if your templating has been good. You do chondral insertion of headless screws at other sites, such as the scaphoid. You do it on the radial head, you do it on the capitellum. So I don't see why this should be a big issue. Finally, if you wanted to defend this technique, you have to look at it critically in the lab. So what we did was we did a 3D CT analysis of this technique, and we published our data in the Journal of Hand Surgery. And what we found was, if you use a 3 millimeter headless screw, then the amount of surface area that is occupied by the screw or violated by the screw is only 8% and 4% of the mated surface area of the MP joint in coronal and sagittal planes. Now, why is that? Because you have to understand that the screw insertion site is in the dorsal 1/3 of the articular surface, which is engaged only in hyperextension, because we have the beauty of nearly 30 degrees of hyperextension at the MP joint. So this is not as much of an issue as it has been made out to be. So what are the keys to success? You must start in the dorsal 1/3 on the metacarpal head. You must template carefully preoperatively. The fourth metacarpal usually takes a smaller screw because it's more gracile, and all the others usually take a 3 millimeter screw. What does the data tell us? Well, since I published my first paper on this technique nearly 12 years ago, there have been more than 50 papers published on this technique. If you do a PubMed search, the total number of fractures fixed by this technique, including phalanges, also exceeds 1100. And all have uniformly and routinely have had excellent functional outcomes. And the rate of complication has been low at less than 3.5%. Finally, biomechanically, this technique has been compared to plating as well as K-wire fixation. And what has been found is that obviously plating does offer you a greater degree of stiffness, but it appears that it may not even be necessary. This technique is certainly as stable, if not more, than K-wires, and it's durable. I looked at my own data, and it's been 12 years since I invented and published this technique. Over the last 12 years, I've fixed approximately 40 fractures, if not more. All of them have achieved a total active motion of more than 240 degrees. And I have had only one bent asymptomatic screw in a patient who was fixed and then came to me 2 years later to get clearance for a job. And a radiograph showed that he had bent a screw after smacking a wall a second time. We also looked in our own data when we compared it and combined it with other centers who are doing this technique. We looked at 160 patients and we had only 4 complications: 1 nickel allergy, which we were unaware of, 2 bent screws, one of which I just showed you, and 1 broken screw, for a total complication rate of 2.5%, which is vastly superior to some other complication rates. Finally, this technique has been largely utilized, was described, and promoted as a minimally invasive technique. But you can also use it for formal open reductions. Now, this is a person who came to see me at about 2.5 to 3 weeks. And you can see from this lateral radiograph that the proximal and the distal fragments are completely bayoneted. So there was no chance that I could do a close reduction on this. So I did a formal open reduction and fixed it in this technique. And what you can see is at just about 5 weeks, the patient has full function and is back to a full level of activity, including his job, manipulating heavy equipment. So just in case you think I'm completely delighted, yes, I'm completely delighted about this technique. And I thought I had invented something really special until Tom Fisher, an old and dear friend of mine, sent me this picture. This is a picture from Gottfried Sigmiller's textbook from 1977, where a similar technique was utilized with a headed screw. Clearly, we have advanced since then and we are using headless screws. But just in case you think you invented something new, do a very detailed lit search. You'll be surprised what you can find. So that was very humbling. So thank you very much for this opportunity. And I'm delighted to have shared my experience with you. Thank you.
Thank you, Jai. That was absolutely fantastic. Hemant, any comments?
I would say that is a very excellent paper or excellent presentation. I was one of the, I would say, people who would say, Kiare, you're going through the articular surface. But I think now after seeing him, I think I should change my opinion.
Yeah. Would you like me to respond, Sudhir?
Yes, of course.
You know, it's orthopedic surgeons have been trained to think about articular cartilage defects as being anathema, right? And you don't want to make articular cartilage defects until you make them. Yet we do that without thinking twice when you're fixing radial heads or proximal folds or even the capitellum. But yet when it comes to the metacarpal, we seem to have a mental block. And my job is just to take down that mental block. You know, I had one until I didn't have it. So.
Jai, can I ask a question?
Yes.
This is obviously a fantastic technique, right? And it's really changed everybody's practice, including myself. So thank you it's nice to hear it again. People are now doing it for phalanges, right?
Yeah.
Now, in the phalanx, I'm quite concerned. I know cartilage loss is not that critical, but in the phalanx, the footprint of a screw is pretty large.
Yes.
What is your feeling about taking this technique to the proximal phalanx?
See, Randeep, it's like when the genie is out of the bottle, you can't put it back in. And putting a screw in the intramedullary canal of P1 is okay, as long as you go antegrade. You could go retrograde through the PIP if you go with a smaller diameter screw. But if you go with a 3 millimeter screw, the footprint is enormous. If you go antegrade, you can go in the dorsal third of the articular surface and still get away with it. But I have significant concerns about people who are putting screws in proximal phalanges and middle phalanges willy-nilly and publishing their data. I have significant concerns. But like I said, I let the genie out of the bottle. I can't control it anymore.
Can I ask a question to Chait?
Of course.
Sudhir?
Yeah, go on.
Yeah. Actually, I want to know whether this technique of intramedullary headless screw fixation can be used for proximal third fractures, comminuted fractures, and spiral long oblique fractures of the metacarpal.
I think it can be used for proximal third. So there are two ways I would answer this, Hemant. There is some data to show that if you were to drill the K-wire out the proximal end and flex the wrist all the way, you could actually put a screw antegrade for proximal third fractures.
Oh,
You could do that. That's one way of doing it. The second way of doing it is to bury the screw all the way into the medullary canal, because the current length of the screws of the company that I use, the largest length is only about 45 millimeters. So for me, it is challenging. But there are other commercially available screws which come up to 60, 70 millimeters in length, and you could certainly use those. But my biggest concern is for comminuted fractures, also you could do it provided you rely on this screw only as an internal splint. This screw was never designed to be anything more than that. I really thought of it as an internal splint. And anyone who talks about compression and all that is a bunch of hooey as far as I'm concerned. So it's an internal splint, and therefore I'm very concerned about using it in spiral fractures. Because you have to think about it, these are differential pitch screws. And differential pitch screws are designed to exert a degree of compression. So if you use them in fractures that are longitudinally unstable because of obliquity or spiral nature, they will behave what they are created to do.
exactly.
So that's why I don't use them in those.
Yeah. Okay. Thanks.
Okay, Sudhir, can we look at some of the questions which have been typing in the chat box for both Dr. Patankar and Dr. Mudgal, and let them answer it live?
Yeah, a lot of things have happened. Yeah, I'll start with Chai that we're talking about that technique. There's a question similar to what Hemant asked about whether you'd use them in boxers fractures.
So you can use them in boxers fractures. So here, I want to make this very clear. Most metacarpal neck fractures can be safely treated non-operatively. Okay, so please, 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 don't get me wrong. This technique was created for subcapital fractures, and it has now been expanded to involve displaced, angulated fractures of the shaft or the proximal third, as the case may be. But I do not want this technique to be thought of as wanting to fix every boxer's fractures that walks through your door. I don't think that is what my message is. I know that's not my message. Boxer's fractures up to 45 degrees, 50 degrees of angulation can be treated safely non-operatively. But if there's angulation more than that, or if there's angulation with malrotation, sure, you can use it.
I suppose you need to throw in some caution by saying that you need to look at the amount of comminution, and also if there's a concomitant fracture of the head, where then this method would be rather difficult to use in that situation.
Absolutely, unquestionably. And more importantly, when you measure the angulation on a boxer's fracture, please make sure you have a true lateral view. And don't forget that there's a 15-degree angulation that pre-exists between the head and the neck. So whatever measurement you come up with, please subtract 15 degrees from that before you come up with a real number. I would say 95 out of 100 times you can treat this non-operatively.
And when you're treating them non-operatively, how effective is the JAS maneuver for reducing it and holding it up there, if you're treating it conservatively?
So I have abandoned the JAS maneuver for non-operative treatment because I feel that it's singularly ineffective and reasonably useless because it doesn't work. It's a very challenging part of anatomy to hold with a splint. So we had done this. We had looked at this about 30 years ago. We had done Les Kleinerman and Neil Anand had looked at these fractures, and they published the data in a journal of in Injury. And they looked at these fractures where they just wrapped them with ACE wrap. And what we found was even up to 60 degrees of angulation was perfectly fine. There was no manipulation, nothing of the sort. Of course, you can't equate every fracture to be the same. If your patient is a manual laborer, you have to think about whether the prominence of the metacarpal head in the palm might be a problem. If your patient is an executive who sits and types all day, it's a no-brainer. Leave it alone. But it's a manual laborer, you may have to rethink the whole thing. But manipulating it and hoping to hold it with a plaster splint, for me, I'm not that skilled.
That's exactly the reason why I was asking that if you need to manipulate it and put it back and then hold it in that position, it becomes very difficult unless you use very non-ideal ways of trying to hold it there with very tight plasters in very odd positions. So you tend to then have the fracture collapse if you haven't got that. And as you see them over a period of 3 to 4 weeks, it probably gets back into the same amount of flexion that was there before. So then if you're planning to keep it straight, then you need to stabilize it with an anti-grade wire or whatever other method you use. There's another question. Yeah, sorry.
There are multiple ways to do that. Yeah, absolutely.
Yeah. So there's another question for you. Did you have any infection?
Not yet.
Touch wood. And there's a question I don't think you want to answer, but if you're free to answer, which company screws? And I think that bears some importance, especially when you're talking in the context, the numbers that you've given out about 3 millimeters for the fingers and 2.4 for the ring. I think maybe we will need to, when we adopt this technique, we will need to look at those numbers very, very closely and probably have smaller sizes ready. And until we have those smaller sizes ready, I would say we shouldn't embark on this, because I don't think we do get much smaller screws than the 3.1 headless screw right now. There is probably one company. Do you want to tell us?
I'm comfortable naming the company. So, disclaimer, I'm the chairman of AO North America's Hand Education Committee. I'm on multiple AO courses, much like Randeep and Sudhir. And I use Synthes products all the time. The screws that I've talked about are made by Synthes, but I have no financial connection with any of them. And it's just the level of comfort that I have with them. You could use any companies, you know.
Yes. Should we move on to the case discussions, Sudhir? It's 9:43.
Are there, Hemant, Pankaj, are there any? Yeah.
Hello.
It's 9:43. We'll just take 2 more questions and then move on to the case discussions.
Yeah. Hemant, there's a question about do you need to remove the plates?
Yeah, I have already answered it on the chat box. In case of phalanges, yes, the reason to remove the plates is quite more than in the metacarpals. And in the phalanges, especially if you have tendon adhesions, then you will have to remove the plates and do a tenolysis at the same time. I've already shown one example of the second last case where I had to remove the plate and do a tenolysis. In metacarpals, they may not be required considering these new lower profile plates.
Rujuta, just tell me, these questions in the chat box, are they being seen by the participants as well?
Yes,
No,
yes.
that is why I can see, because I'm logged in from 2 devices, what they are writing there, and I'm putting on the chat box here, because this link is only for us. So that's why if we take them and answer them properly, then it's best.
Yeah, there was a question from Dr. Mukhi, which was about the biopsy for that pathological fracture, but Hemant has responded by saying that it was done in a public hospital and he doesn't have the report at hand. Is that right, Hemant?
Yes, that's right.
And what else is there? Implant removal. And how early do you start mobilization? I think that's about it.
Yeah, that's the last question.
Yeah.
Right.
You could assume that was an enchondroma, right, Hemant? More
Yeah.
than likely.
But I don't have, it was a benign tumor. Patient is still living. And
despite your intervention.
yeah.
we now have some time for case discussion. So, Hemant, would you like
Yeah.
to?
Yeah, I would like to present a case.
And all the faculty is free to discuss.
Yeah. Can we take this case?
Yes, please.
This was a displaced fracture of the second, third, fourth metacarpal shaft following an road traffic accident. The patient was holding an ATV, all-terrain vehicle, and she fell down and the whole ATV handle came on this hand. This was a closed injury. There were other injuries also, some head injury, tibia injury and all those things, and they did not require surgery. So, your take on this?
So, Hemant, do you want me to respond to this?
Yeah, please, please.
So the one thing that I would encourage people to notice is the degree of soft tissue swelling. You know, this is a high energy trauma and the metacarpal fractures are multiple and they're completely displaced. So this is a very high energy injury. So there is no role, in my opinion, of treating this non-operatively. These fractures must be stabilized and the MP joints must be moved right away. Otherwise, that hand is doomed.
Agreed.
How you fix it is entirely up to you.
Your preference? What is your
So, in the years past, I would have probably stabilized these with plates. And if I had the possibility of screws available that are long enough, I would use intermedullary screws. But if I don't, I'm perfectly comfortable plating all of these. So plating allows me to also decompress the intraosseous spaces and allows me to move them on day 5. So this is really, really critical. This hand will be doomed if you don't fix this.
Okay. Randeep?
Yeah, I agree that the problem here is the relative compartment syndrome that's going to happen. So I actually would prefer open and plating, simply because with the 2 incisions that you make, you can actually see the hand shrinks right down, right? Whereas putting intramedullary screws would not address that. And I think a lot of times these people do okay, but they end up stiff, I think, because a lot of the intrinsics are actually toast, right, from the compartment syndrome, which you only realize when you open it and decompress it. So I think open treatment is good for this injury for various reasons.
Okay. Sudhir?
Yeah, I tend to agree with what's been said, but having said that, putting in 3 plates, it's one hell of a job putting in 3 plates. So maybe I would think in terms of putting antegrade wires in the second and the fourth metacarpal and use a plate maybe for the middle metacarpal. The reason for not using an antegrade wire in the middle metacarpal is because the fourth compartment extensors would be right underneath that. And that would be very, very difficult to manage. Unless I use the technique that you use, Hemant, where you clip the wires very, very close to the base and don't bend them like I do.
Yeah, I would also agree with you because these are essentially transverse fractures. So they will do very well with the antegrade wires. What about this?
You didn't show us what you did with that one.
I'll show you. I'm just putting up the cases for discussion.
Oh, okay.
I will show. I'll just run with all the results. These are just the teasers.
Yeah, Pankaj.
How do you treat this? I've got the results of all these cases.
This definitely requires operative intervention in terms of possibly the wound may be open on the volar side, and whenever there is a gap between the distal fragment and the proximal fragment dorsally, I would suspect some soft tissue interposition. This will have to be levered using an intrafocal wire, and the reduction is not very difficult. I would suspect, even if I don't see it on this X-ray, I would suspect an intra-articular fracture. And before I manipulate manipulate this fragment, I would put 1 transverse wire preemptively because I don't want to displace the condyles, and then cross K wires from the collateral recess into the medullary canal. Having said that, uh, the canal may not even accept 2.8 millimeter wires sometimes. So be ready with a 0.6 millimeter wire as well.
This was a closed injury.
Yeah. So I would manipulate it percutaneously, but I will keep in mind that there may be some soft tissue interposition dorsally. Maybe there is maybe the shaft has could have buttonholed through the flexor sheath. Especially if I see a a good shadow between the dorsal fragment and the shaft, the distal fragment and the shaft. But intrafocal wire and lever the distal fragment into reduction.
Because when you say an intrafocal wire, where would you pass the wire?
I would pass it from dorsal proximal, headed towards volar distal, and hitch that wire onto the dorsum of the shaft fragment, and then lever the head fragment into reduction.
Right. Any other tricks, Chai and Randy?
What I've found in these is it looks very much like it's open, or at least it's almost puckered the skin, right? So it looks like the flexor tendon may be interposed, so reduction may be hard. But in these, I tend to put my pin first through the distal phalanx, capture the distal fragment of the middle phalanx. So I have one piece of bone to bring back onto the middle phalanx. I mean, it's a common injury we see in kids, right? With this neck of the second metacarpal. I'm sorry, second middle phalanx. But in this one, I'm thinking an open reduction might be necessary. There's something stuck in there. But I'd still put a wire first, longitudinal, bring it back in, and then put the one wire down.
Okay. Chai?
Yeah, I agree with what has been said, that I have some significant concern about this being almost open. And the neurovascular situation is okay, right, Hemant?
Yeah. This was a closed injury.
So,
No
for
other
me,
problem.
oftentimes when the fracture is so distal, achieving adequate traction can be a challenge. So I will oftentimes put a transverse wire through the base of P3 and use that transverse wire as a traction wire. And that allows me to restore the length. You have to be prepared mentally that when you do that to the transverse wire, it will get bent. So you will have to have some intestinal fortitude to deal with the bent wire, which you have to cut and remove very gently. And once you do that, then the question of pinning it is very easy. For me, I would just go with one longitudinal wire from P3 to P2.
Okay.
But I would have very little threshold to open it, like Randeep said, or like Pankaj said.
Okay. Should I put the third case, Sudhir?
Yes.
You want me to show?
No, go ahead with one more and then we can see the results.
Yeah, I'll show you the results of all the cases. This is another case. This was a young dentist who had this cricket ball injury.
Yeah, in this
Closed.
one, I would.
This
Sorry.
is also closed.
Yeah, in this one, I would use an external fixator with a collateral frame with wires going transverse across, two in the metacarpal, two distal to the fracture. And once I align the articular surfaces, either by manipulation or by joysticking the articular surface into place, I'd have maybe a couple of subarticular wires acting as draft wires there. I would definitely be a little worried about trying to open this one.
Any role of bone grafting and restoration of the cartilage or articular surface?
I think
corticocancellous bone graft.
Right. I think if you're going to open it, then you might well require that.
Okay.
In my hands, this would get a CT first, but if you don't have one,
no, I didn't do it.
I'm reasonably sure, based on what I see, that I could address this with a formal open reduction and restoration of the articular surface. I would keep ladder plates available, and I would use a ladder plate for this. So I think this is fixable internally.
Randeep?
I like to do a traction view intraoperatively, Hemant. And if these people come reasonably soon, then like Chai, I would feel like I can put the articular surface back together. I do often use spanning plates. So sometimes I'll put a place across the MP joint and take it out 2 months later.
Right.
For bone graft, I like calcium phosphate because you can fill it with calcium phosphate, like inject it. It really fills it in well, and then you can put screws across it. I tend to prefer that to cancellous bone in smaller defects of the hand.
Okay. Sudhir, I'll show the results of all these 3 cases now.
Yeah, go on.
Yeah. This was the lady with multiple, with that ATV accident with 3 metacarpal fractures. You can see a lot of swelling. And this was her fracture. And this I treated with close reduction and antegrade intramedullary K wires, sparing the extensor tendons.
Mhm.
That was the 6 months post-op result. I cut the wires absolutely flush with the metacarpal basis. So there is no question of removal. And this is the result. You can see the transverse incision here, and through which I put these wires. So this effectively decompress those
Yep.
spaces also. And
Yep.
that's the result at 6 months.
Wonderful.
This is that case of the fracture of the neck of the middle phalanx. This was treated again with a close reduction and antegrade intramedullary K wires. 0.8 millimeter wires were used. And that is the result at 1 year. This technique was published by me in 2014
Yes.
in the journal. This was the young dentist with a closed injury of the thumb. This was treated with a combination of a cortico-cancellous bone graft. What I do is when there is a large defect, I take cancellous grafts and then put it in a small syringe, a 2 ml syringe, or even you can take a diabetic insulin syringe and
Yes.
just put all the grafts and just compress them. And you
Yes.
get a nice chunk like this here. And I used a cortical piece here. I put a fixator, as Sudhir has rightly said, and then just held it like this. Now, the important thing in this case, if you use a fixator for the thumb, just remember that your proximal phalanx should be in line with the metacarpal. Many times the proximal phalanx extends at the fracture site. So the graft has to be put in such a way that the proximal phalanx flexes slightly anteriorly. You can see this cortical graft, which is forcing the proximal phalanx in. I did not have a plate at that time. And this is the result at 6 weeks. We try to see how much union has occurred by removing the fixator but keeping the wires. So if need be, we can extend the fixator. And this is the result. This fracture is completely healed. You can see that the proximal phalanx has aligned itself properly. The fracture has healed.
Sure.
And that is the result at 6 months.
Very nice. Hemant, if I may suggest that you use the insulin syringe, tuberculin syringe is also very good. And then the other thing is, the one thing that I tell my residents and fellows is the best kept secret in hand surgery is threaded K wires.
Yes.
You drill them once at low speed. We've talked about this.
Yes. Yes.
You drill them once at low speed and you cut them flush, and they're wonderful headless screws.
I agree.
Oh, that looks wonderful.
Yeah. Sudhir, can I stop sharing my screen?
No, you have any more cases? We have 5 more minutes.
So
Do you
then
have any more cases, Hemant?
I have.
what would you like to do? Would you like me to read out the questions from YouTube regarding these cases, or?
Oh, yes, of course. Oh, yes, of course.
Yeah. So Dr. Mukhi has asked things like cross K wire open and Japanese technique closed. Your opinion?
Regarding
Japanese technique, his opinion, closed.
Japanese technique for what?
Probably the Suzuki technique that you use for the PIP joint For one that is displaced as far as this one, I think that probably wouldn't be the ideal technique to apply. And what was the other question?
Cross K-wire open.
Well, that's one way of doing it. That's one way of doing it. You open it up and you reduce it, and then the way you choose to fix it, you keep the principles in mind that you leave the joint free and you get it stable enough to start moving immediately. So cross K-wire is perfectly fine. I would pass in the actual wire from the terminal links into the fracture and across this fragment, and then wires and remove the axial wires rather than leaving it the axial wire. Any other questions, Rujita?
Yeah, multiple metacarpal fracture case. Should it be an immediate surgery or waiting for swelling to reduce?
Yeah. If the swelling is excessive, I would like to wait, because if I'm going to do an antegrade intramedullary wires, it's quite difficult. You wait for about 4 days, let the swelling reduce.
But if you are suspecting compartment syndrome that might happen, then I think you should be going in immediately.
Yeah, but if you're not suspecting a compartment syndrome, you should wait.
So then how do you suspect a compartment syndrome in the hand, and how do you not suspect a compartment syndrome?
If you read too much about it, then you will suspect it.
It's very difficult because stretch pain and stuff like that, compartment pressure measurements and things like that are out. So it's generally, I think most of us book on table, it's almost 24 hours minimum.
Okay, so that's very nice, lovely, excellent first session.
Pankaj, any thought?
Yeah, so I was also thinking about the timing of surgeries. I think at slightest doubt of compartment, if you can't disprove it, go ahead and decompress at the first opportunity that you get in the operating room.
Right. Hemant, would you like to take the next session?
Yeah, let's start the next session, please.
Yeah. The next session is on the PIP joint, deciphering the PIP enigma. And I would like to invite Randy Bindra to deliver to give his presentation.
Thank you, Hemant. For those of you who don't know, I actually trained at JJ Hospital, and I still have brown eyes. I don't know where the blue eyes came from, but everything I learned from Sudhir and Hemant. And after seeing Hemant's talk, I don't know if I can show results as good as Hemant does for each and every case, but I'll do my best. And thank you, Sangeet. Thank you, Rujita, for the invitation. So I've got 20 minutes. So what I'm going to do is talk about acute PIP injuries and the use of plated screws. This is where I currently live and work. So I live on the Gold Coast, which is about halfway down the east coast of Australia. And the biggest city next to us is Brisbane. And we have some nice beaches, 40 kilometers of them. So it's like a long chowpatty, if you like. No horses and no pani puri. These are my disclosures, but none of these will have any impact on the cases I'm going to show. Now, the problem with the PIP joint, and I liken the PIP joint to the elbow. So think of it as having a stiff elbow. You can't live with a stiff elbow. So the MP joint is like a shoulder. You can put a screw in it, doesn't matter. It's got big cartilage. PIP joint can't get stiff. DIP is like the wrist. You can live with a little stiff wrist, but you need to get that PIP moving. We know it gets stiff easily, just like an elbow. So you want to start moving early. When these are unstable, it's really hard to maintain, almost like a terrible triad injury. And most often, I'm sure you see that in India as well, these are cricketers, sportsmen, fighters, all kinds of young guys who take about 3 or 4 weeks before they realize something's wrong or broken. And the surgery that we do in itself can contribute to stiffness. So unless you're a skilled artist like Hemant, most of us, by the time we've done an operation, we've added on to the insult of the injury. So you want to keep your surgery to a minimum. Now, the goals in order of priority are, the first thing is you want to get the joint aligned. So if the joint is not aligned, they're going to get arthritis, pain, and a poor result. So the first thing, most critical, of course, is joint alignment. Even if you can't get them moving fully, you want a little bit of movement happening. So even if you start a short arc of motion and you tell a therapist, that's good to keep that cartilage moving. And the congruency of the reduction is probably not as critical as the alignment. But if you can get it congruent, obviously, that's a better option. Now, you can't apply the same operation to every person. And, you know, oftentimes in orthopedic meetings, we talk about x-rays, right, as you just saw, and we give opinion on x-rays. But often it's important to look away from the x-ray at the patient. How old is the patient? What are their needs? Is it a jeweler, surgeon, sportsman? Like, so they would treat, and you got to figure out what they need, and then you decide the treatment that would suit them the best. How long has it been from the injury? That's important. What's the condition of the soft tissue? Is the finger very swollen or not? It's important to get good imaging, a CT scan in some of these complex fractures. Very important to know what's the condition of the dorsal cartilage. Do I have room, intact dorsal cartilage, where I can buttress these volar fragments too? And what is my experience and comfort? Do I have the 1 millimeter screws like Hemant has available? Or are my minimum screws 2 millimeters or 3 millimeters? Can I do some of these complicated techniques? I'm going to split this talk into two. The proximal end, so the proximal phalanx condyles, and the distal end, which is the base of the middle phalanx. Now, looking at the proximal phalanx condyles, here is an example. This is an injury playing cricket, finger dislocated. He relocated the finger, continued to play, and 3 days later went for an x-ray because the finger swelling hadn't come down and the finger wasn't moving. And then they realized that perhaps things don't exactly look right. And when you take a close look at it, you realize that the proximal condyle has spun, and as he's reduced it, it's kind of rotated 180. So this one needs open reduction, right? It's impossible to get that bone flipped over and reduced without an open operation. A mid-lateral approach is a great approach for the PIP joint because you can get volar and dorsal, and you can get a good view of the joint. As soon as you elevate the extensor mechanism, in this case, you can see the fractured surface of that bone. And once we flip that bone back, we make an x-ray to make sure it looks good, and then put in a couple of screws. And what you think are perfect screws could often not be right. So be careful to always get an x-ray before you finish the case. So we use a mini C-arm, make sure the screw direction is corrected so it looks right. Now, one of the important things when you're putting screws at the PIP joint level is to pay respect to the collateral ligament. So if you look at it, the distal screw is actually sunk beneath the collateral, so it won't snag the collateral. And the other thing is you don't want your screw too long so that it catches the collateral ligament on the other side. So make sure your screw is sunk beneath the collateral and not long on the opposite side. And this is the kind of outcome we get. Remember, you can get some DIP stiffness with these injuries, so always start them moving the DIP early. The fingers tend to always look a bit swollen. I warn my patients, you may not get your wedding ring back on that finger because the joint always looks a bit puffy, and a slight flexion deformity is common unless your doctor is Dr. Patankar. Now, in this case, a CT scan is a must because when you look at these proximal condyles, you realize it probably is not as straightforward as it looks. And these are multiple fragments. So there's a fragment here, there's a fragment here. So now this one, we need to treat almost like the trochlea of the humerus. So I like to do the same mid-lateral skin incision and then split between the central slip and the lateral band so that I can lift and expose the trochlea or the head of the proximal phalanx completely, but my central strip attachment remains intact. Then we reconstruct the articular surface by putting all the fragments together and a stabilizing K-wire, as you can see here. Now we want to capture this with a plate. So either you can put a mid-lateral plate, or in this case, I used a dorsal plate with the T configuration going around the fragments and compressing them together. And then you can simply close the lateral and central slips together and get them moving early. And here is the patient. We did not need to take the plate out, but this would certainly be an indication for plate removal because the plate has been applied quite dorsally and quite distally. Now, when we come to the middle phalanx base, these are the ones that are a nightmare, right? So this now is like your terrible triad. It's like the coronoid of the ulna that's going to keep you from becoming stable. Now, we know from these figures from the AO website, the easy ones I'm not talking about. These are pure dorsal dislocations. You reduce these, they are stable. Okay, I'm not going to talk about these. These are complete dislocations. Again, you reduce these, they are stable. You can put them in buddy taping, get them early moving, they're okay. The ones you want to be careful about are the volar dislocations, which happen about 1% of the time. In those, there's a central slip injury. So those ones need to be splinted straight and immobilized for 3 weeks, or use a yoke type relative motion splint so you let the central slip heal. So volar dislocations have to be kept still. All dorsal dislocations can be mobilized early. However, when you have a fragment that starts to get more than 30%, so anywhere from 30 to 50%, what happens is not only do you not have a stable bony configuration, your ligaments are now all attached here. So your dorsal fragment or your middle phalanx has no soft tissue stabilization and no bony congruity. So very hard to keep your reduction. So what we know is at 30%, it's kind of touch and go. By 50% of fragment size, you're definitely in an unstable situation and you may have to look at surgery. Now, the simplest technique, and this is the technique I like a lot, and this to me in my hands is much better than an extension blocking splint, is a blocking K-wire because it doesn't fall off, it stays in place. The only side effect is you get a synovial fistula because your wire is going directly into a joint. So you must take these pins out before 21 days or you'll get a synovial fistula infection and stiffness. And because there is no insult of surgery, these patients do pretty well. Again, you can see that DIP joint does take a hit because the central slip is kind of snagged by that wire. Now, when the dorsal cortex is comminuted, this is not the simple fracture that you can treat with an extension blocking wire. This is a pilon fracture, right? There's a central depression, dorsal and volar comminution. I like the technique described by Hines and Giddens. So you put two parallel wires, one wire through the head of the proximal phalanx, the second parallel to the first wire. Then you make two bends, one here and one here at 90 degrees. And then you bend this wire against the other wire. Now, this is easier than Suzuki because you don't have rubber bands and you can increase the tension by putting a spreader between those two wires, or you can decrease the tension by putting a hemostat and squeezing those two wires down. So I like this kind of an external fixator. They both are 1.1 millimeter K wires. And this is the kind of distraction you get. You can put a small joystick through a small incision and correct the depression and hold it down in these kind of cases. Now, when we get to fragments that are more than 40%, a CT scan helps you for two reasons. It shows you the dorsal cortex is intact, and it shows you where most of the depression is. And in this case, it's eccentric. Now, you may argue that this fragment is only 20%, but because there is depression beyond that, the effective depression is 50% in this case. So it's important to not only think of the fragment, but look at the adjoining depression. Now, in the past, traditionally, I would do a full shotgun approach, correct the depression, put the screws. Now, I use a more conservative approach where I look at this almost like a volar Barton fracture of the distal radius. So here's our Brunner incision. You can split the FDS to get a nice wide exposure, and you have one FDS slip on either side. Now you incise the collateral ligaments on either side, leave the volar plate attached to the distal fragments, and elevate the distal fragments with the volar plate. So you're almost doing like a volar button where you're pulling it back, then correcting the joint depression. So here we are. The joint depression is corrected. Volar plate is put back. You put your wires and get an X-ray. Now the joint is stable. And then you can apply any kind of a buttress plate onto that fragment. And you can cover the plate with the flexor sheath so there is no issue of tendon irritation. And you can start moving them early with some kind of an extension blocking splint. So I like this technique rather than doing the full-blown shotgun using a buttress plate. Sometimes the fracture is on one side only. And then in that case, once again, you simply do a mid-lateral incision, buttress it against the intact cortex on the opposite side, and apply your plate. And your plate can capture the volar fragment. You don't have to put a screw here, simply capture it and get the stabilization. Now, when you look at the outcomes of these injuries, no one has compared X-fix versus wires. There are simply short series of each technique. I think it's very hard to compare one versus the other. What I would say is most patients end up with a slight flexion deformity. It's very hard to get full range of motion. So I warn my patients, you may not get full movement. I think if you do open reduction and external fixator and you do it well, you can get pretty similar outcomes. But open reduction has higher complications. So you need to be very facile at using these small screws. If you don't have the available technique, use an X-fix, probably safer. Whenever a patient presents late, I think generally it's difficult to get a good outcome, even with a Hemi-hamate. But certainly the Hemi-hamate has changed the way we do these cases now. And obviously the more important thing is getting the joint reduced rather than worrying about congruity. So when do I open these? Certainly for a proximal phalanx condyle, external fixator has no role. You can use external fixator for the concave side. For the convex side, you have to stabilize it with screws, wires, or something, but get that fixed. When there's an eccentric depression, more on one side than the other, I think open reduction is better. And when they come late, you need to do an open reduction to release the tight collateral ligaments. But you need a patient who can understand and who can rehabilitate. Otherwise, you're going to get a poor result. When do I do an external fixator? When I'm not happy that this patient can cooperate, if the bone quality is soft, so like an elderly person, and when the patient presents early enough and there's not too much joint depression, certainly it's less traumatic. So let's look at this treatment algorithm. So whenever I see the patient, first thing, do a close reduction in emergency room, okay? And you look at unstable, reducible, or unreducible. If they are reducible but unstable, then you can just do pinning external blocking splint, or you can put an external fixator. But if it's very impacted or they're presenting late, you're going to open. If it's unreducible, you can try gradual distraction using some kind of a distraction device. I tend to use a Hemi-hamate now, as Pankaj will be showing you in the next lecture. I think my key message for you to take home is you got to get the joint aligned and you got to keep it stable by the simplest means possible in your hand. So I start with extension blocking splint, extension blocking wire. I'll consider using an external fixator. And if I think those three will not work, the patient presents late, I'll do an ORIF. Thank you.
Thank you. Thank you, Randeep. That was an excellent presentation. I think I will ask Pankaj to share his screen now. And he will be speaking on the Hemi-hamate osteocartilaginous replacement for neglected injuries.
Can you see my screen, sir?
Yes.
Yes.
Hello. Yeah. Yeah. Good morning, everyone, and thank you, BOS, for giving me this opportunity. I will, over next 15 minutes, I will take you through the neglected dislocations of the PIP joint. Whenever a PIP joint dislocates, this is the commonest variety of dislocation that we see, where there is a volar lip fracture, and all it takes to reduce this joint is a good stable fixation of the volar lip, and it would yield a good result. It may not always be possible to reduce the volar lip to its anatomical position, as in this case, there was this intervening articular fragment which had shifted dorsally. I simply excised it and fixed the volar lip fragment to the dorsal by reducing the anteroposterior diameter of the P2 base, and it still gave me a stable and congruous joint and yielded a good range of motion. Sometimes the fracture fragment, the dorsal lip is so comminuted to anatomically reduce these fragments and fix them stable using a metallic implant. And in such cases, one can simply put the soft tissues together and put a dorsal pull-out suture to get a good congruous joint. And once you have a congruous joint and little bit flexion deformity to start with, you have a joint on which you can put in a lot of work over next coming months and restore a useful range of movement. Sometimes with this was about 5 months presentation and more than 60% of volar lip involved, it is virtually impossible to restore the volar lip. The focus on this in such cases is to somehow restore the volar restraint in this area, if not bony, using the soft tissues. So here is a case where this was a 3-month-old presentation, a very tiny fragment. Looking at more than 50% available surface, I decided to do what is called as a volar plate arthroplasty with an extension block wire. Once the extension block wire was removed, there was still some subluxation of the joint. So what exactly is a volar plate arthroplasty? This is the volar plate to which the volar lip fragment, your fractured fragments, are attached. Ideally, you would want these fracture fragments to go and sit where they belong. But if in presence of severe comminution, late presentation, these fragments may have to be removed. And the gap that results is now filled with the volar plate, which is fixed to the articular margin using a pull-out suture. This is a very good method if you have less than 50% bone loss. And even if there are early arthritic changes on the head of P1, this can still be employed. Problem, however, is recurrence of subluxation because of stretching of the soft tissues, as happened in this case. However, despite that small little subluxation, there was a good functional outcome. This was another case presented late with articular depression and a dorsal lip fracture. It was treated in an external fixator by the index surgeon. And I opened this through a volar approach and saw this large volar lip, and I detached the volar plate with some bony fragments. With an extension block wire, I reduced the joint, and I hoped that a volar plate arthroplasty would work here. And this was the intraoperative picture. It was clearly not the right choice. As you can see, the joint completely dislocated, what is called as a V sign. The volar plate fragment did not hold where I had put it, and it was a disaster. And it has resulted in a stiff finger. So why did this happen in this joint? So if you look at this sagittal section of the PIP joint, and let me convert it to a schematic drawing. Here it is. It is this area that we are talking about, the volar lip. What happens is whenever the extensor tendon and the FDS, they are not attached in front of each other. So because of their attachment being not at the same level on the P2, they create a torque which with a center which is slightly away from the articular surface of PIP joint. And when the volar lip fractures, the only restraint that was preventing this torque from dislocating the joint now can dislocate the joint. The FDS pulls the distal part of of P2 in flexion, and it causes dislocation. And therefore, the most effective way of reducing this dislocation, whether acute or chronic, is to restore this volar bony block or volar bony restraint. So this is the block that we are talking about. Now, how do we restore this bony block? As I said, there are cases in which because of severe comminution, late presentation, it may not be possible to anatomically reduce these fragments. And these are the cases that we are talking about. In such cases, we simply discard these bony pieces and replace it using an osteochondral graft where the articular surface can match. And the most reliable source of this osteoarticular graft is the distal surface of the hamate, distal dorsal surface of the hamate. So this is how it is done. This is the dislocation. This is the fracture dislocation about 5.5 months post injury. Just for convenience, I will flip it over. This is how you would see intraoperatively. You're operating from the volar side. What we need to do in order to put the graft on this surface, what you need to do is dislocate this joint. You must have free access to the volar lip of P2, and therefore you do what is called as a shotgun maneuver. Now your volar lip of P2 is freely accessible to you for you to fix the hemi-hamate graft. However, it's important to do a safe dislocation, and we'll see in few minutes how to do a safe dislocation. Once you have done the shotgun maneuver, you will see the base of P2. These are the malunited and depressed articular fragments. These fragments are simply excised to create a nice rectangular defect to receive the osteochondral graft from the hamate, which is fixed using multiple screws. And then as I said, the key steps are the key step is the shotgun maneuver, and then excising the depressed fragments and creating the rectangular defect, and that is a hemi-hamate graft. Hemi-hamate graft is harvested according to the size of the defect that you have created, and then you shape it to fit perfectly. And eventually it is fixed using 3 screws. And this is the end result that you would get at about 3 months after you have fixed the fragment. So the important step in the hemi-hamate autograft fixation is safe dislocation of the joint, and you must gain full flexion of the PIP joint before you close your wound. And the graft has to be, of course, very securely fixed for early mobilization. You need to get them moving early. So how do you do safe dislocation? The step number 1 for safe dislocation is to reduce overriding of the phalanges. Given late presentations, it's not uncommon to find the phalanges overriding by a few millimeters. One of the simplest things to do is to put a unilateral or a bilateral external fixator and stretch it over next 6-7 days. Once the joint is once the overriding is corrected, then you can go ahead with the surgery. So this is one example of a bilateral frame used for correcting the overriding. From this, we get to this, and then you can go ahead with the surgery of the autograft fixation. Another thing that is required is intraoperatively recession of the collateral ligaments. The collateral ligaments are recessed as a periosteal flap on either side of P2. They are not completely detached. The accessory collateral ligaments can be completely cut. However, the collateral ligament proper should only be recessed for you to effect a safe dislocation. And then once the overriding is corrected and the collateral ligaments are recessed, then you can do what is called as a shotgun maneuver in order to dislocate the joint. One of the dreaded complications while doing a shotgun maneuver is the fracture of the dorsal lip. Remember, your entire surgery depends upon integrity of the dorsal lip. That is where you are going to fix your osteochondral graft. This happens because the dorsal lip can sometimes hinge onto the dorsal surface of the P1. It is useful. There is a useful trick to avoid this complication. Before you start dislocating the joint, you can pass a 1.2 millimeter K wire into the gap. In fact, you can pass two parallel K wires. They are not into the bone anywhere. They are just between the gap. And now you just like you now glide the base of P2 over this K wire so that it doesn't hinge onto the P1. For those who would do their first few hemi-hamate surgeries, I would suggest to use this trick to avoid the dislocation. Once you are used to this shotgun maneuver, then this may not be necessary. The second possible potential complication is the stripping of the extensor tendons. Remember, when you do a shotgun maneuver, the base of P2 may not exactly be at level with P1, and there is a constant tendency for the surgeon to keep pushing it up for a better view. And doing so, there can be some stripping of the extensor tendon. This should clearly be avoided. And the third problem that we face is gaining flexion. Remember, if you do not gain flexion before fixing your autograft, it's going to be very difficult to do it after you fix your autograft. And if you do not get it during surgery, you are unlikely to get it after surgery. So the restriction to flexion comes from the tightness of the tissues all around the PIP joint. The volar tissues may be contracted. There is a malunited fragment. The collateral ligaments are contracted. The dorsal capsule may be other end and contracted. And even the extensor tendons have not glided for quite some time, and they could be other end. During your surgical approach, you have already taken care of the volar tissues. During your recession and when you're correcting the overriding, you are taken care of the collateral ligaments. Now you can take a curved periosteum elevator or a Freyr's elevator and release the dorsal capsule from the dorsal surface of the P1. The periosteum elevator can also be glided between the extensor tendon and the periosteum as far away as middle of P1 in order to ensure that there is no adhesions between the extensor tendon and P1. Thereby, you will achieve a complete flexion. Once complete flexion is achieved and a shotgun maneuver is done, then comes the hemi-hamate graft. Sizing of the graft is important because you do not want to spend too much time chiseling the graft once it has been harvested. Remember, it is useful to take a graft which is larger than your original, creating a defect which is larger than your original comminuted pieces. You don't want a situation where you create a very small defect. Take a very small graft, and then find it difficult fixing it using 2-3 screws. It's much better that you create a larger defect, take a larger graft. Our aim is to create this volar lip. But remember, your osteochondral graft is not going to be of this shape. It will be something like this. So as long as you get a good volar lip, this bump is of no consequences. In fact, when you get this bump on the metaphyseal area, you know that you have done a good job. A few things about the hemi-hamate graft. So this is the articular surface of the hamate and the articulation for the fifth and the fourth metacarpal. You would go from the dorsal side, you will make the two coronal sagittal cuts first, then you will make the coronal cut, and the last one is your transverse axial cut. This is the most difficult cut that that you will be making, and you want to center this graft roughly around the crest here, so that it matches with the articular surface of P2 base. The last cut that you make is the most difficult cut, that, as I said, this one. And in order to make it, you can simply depress the metacarpals down and make this cut from distal to proximal, or you can actually chip off the base of the fourth and the fifth metacarpals so that you know exactly where to cut. This hemi-hamate graft is not a very well-behaved structure. There are certain issues with it. One, you instead of having a nice rectangular graft, you might end up having a trapezoidal graft, and it is impossible to fit the trapezoidal graft in the rectangular defect. So please avoid this complication. This articular ridge is not as central as you see here. It is not perpendicular to the dorsal surface. Many times, in most cases, you will see that it is obliquely placed like this, and therefore, when you take a rectangular graft, you will find that the ridge is going like this. Yeah, I've seen that it's safe to ignore this. Even if this ridge is not matching with that of the P2 base, your joint will still move well. And the last part is the ulnar limit of the hamate. Actually, this ridge is not centrally placed, and you can sometimes barely have only 6 to 7 millimeters of the ulnar half beyond this ridge. And when you take a graft which is say 8 millimeters wide, so it is 4 millimeters on either side of the ridge, you'll end up having a very thin shell, just 2 millimeter shell on the ulnar side. And it is not uncommon for me to fracture this ulnar wall. It doesn't create much problem, except that there is some residual pain for about 3 to 4 weeks until that part heals. Once the graft has been harvested, the key principles of osteosynthesis have to be followed. There has to be good opposition between the graft and the recipient defect in P2. If required, you may need to insert a few cancellous chips to fill the gaps. Fixation should be done with the bone fragments compressed. It should be compressed either with a bone clamp, or you should use a lag screw principle. Minimum 3 screws have to be used. The screws must have bicortical purchase. A millimeter projection on the dorsum of base of P2 does not hamper the function of extensor tendons. The screws should preferably 1 millimeter diameter, or at the most 1.3 millimeter maximum. 1.5 millimeter screw onwards are not suitable. Your graft will shatter. You will not get 3 screws. And the head of 1.5 millimeter screw is fairly large, and it will project on the flexor surface too much. Once the graft has been fixed, the attention has to be placed on the soft tissue closure. The volar plate and the accessory collateral ligaments have to be closed back. Only in one case I have used an anchor to fix the volar plate back. Now I don't use it. I simply suture it to the tissues on either side of the midline. And the A3 pulley flap is always sutured under the flexor tendons, covering the screw head, so that the flexor tendons are not irritated. All in all, hemi-hamate arthroplasty is not a difficult surgery, though there is a bit of a learning curve. It is best to start with a couple of times in a cadaver hand. What you don't want to do is compromise on equipment and implant. This is one thing that will make your surgery very difficult if you don't use the correct equipment and the correct implant. You must strive for full range of motion and a congruous joint during surgery. If you don't achieve them during surgery, it's not likely that you will achieve it later. Thank you for your listening. On behalf of Indian Society for Surgery of the Hand, I welcome all of you to join ISSH. Just visit the website and apply. Thank you very much.
Thank you, Pankaj. That was again a very crisp and excellent demonstration of the hemi-hamate graft. Any questions, Sudeep?
So I think you can generate a discussion amongst yourself as of now. I will relay any questions if they are coming.
Right. We're waiting. While we wait for questions, I have some comments. So one was that I just enjoyed both the talks. Of course, Randy's talk was so much more nicer to hear because of the little, the little things that always worry you. That is this bone? Can I fix this bone? Should I, not see these fracture fragments all together like we saw in some of the presentations? And we know that if you hold everything in a good stable position and mobilize them early, you get to see very, very good results. So that's fantastic. And from Pankaj's masterly exposition on the hemi-hamate, I wonder if, if these type of lectures were there 10 years ago, maybe we would have started on doing these hemi-hamates that much earlier. I saw Hill Hastings in Vellore for the first time, and I I thought this is not for me. I just will never ever be able to do something as delicate as that. Obviously, then we also didn't have the screws and things like that. Then, of course, with the exposure and the kind of cases we saw so commonly because of cricket injuries, a lot of us have taken to that. And it's fantastic that you pointed out all the pitfalls, because that's what always, each time you do one of these cases, you find that there's something different from the previous one. And like you mentioned about the central ridge never matching, there's a lot of studies now talking about how different actually the dorsal surface of the hamate, I mean the articular surface of the hamate is from the PIP joint, and yet it gives a good result. So it's the block that actually does a lot to keep it stable. Try any comments before you go off to bed?
No, I thought that was spectacular, to be perfectly honest. The couple things that I mean, from the school of hard knocks, and when you shotgun the PIP joint, oftentimes you can exploit Camper's chiasm. And the way I do that is literally split it a little more. So you allow that, gives you an easier shotgun by splitting it even further. So that's number one. And number two is, I don't know if Pankaj, you covered that. I was busy having dinner, but when you're harvesting the graft, it oftentimes over the dorsal aspect of the hamate, I use a transverse cut 2 millimeters proximal to the intended cut, and that 2 millimeters of graft, I rongeur it out so that when I put my curved osteotome in, I get more of a transverse harvest than an oblique harvest. So it allows for the trajectory of my osteotome is better by doing that transverse cut 2 millimeters proximal. And I think that's something I learned from Hill, and it seems to work very well. But that's just it. But I think everything else was very, very wonderfully demonstrated. But thank you.
So I think let's go on to cases then.
Yeah. Shall I project the presentation now?
Yes.
Yes, please.
Yes.
I will just share my screen. Can you see my first slide?
You can see the title.
Yeah.
Not yet. We are seeing your desktop.
Randeep is also phenomenal, and I wish I would have cases to show like Randeep's, but I don't seem to have outcomes that are similar. Maybe.
Can you see? Don't play enough cricket in Boston.
No, I think you'll have to unshare.
Maybe the Australians are good at rehabbing the fingers. Of course, with surgical skill, of course, but. Yeah.
Can you now see?
Yes, yes, yes.
Yeah. Okay. Here we go. The case one was contributed by Dr. Bindra. So Dr. Bindra, would you want to take over?
Yeah, sure. So this is slightly different because this is firstly your anesthetist son, right? So if your anesthetist son comes to you and you mess this up, you're screwed for the rest of your life, right? Every case will go slow and everything like that. So straightforward, right? She said, my son dislocated his finger. They put it back in the emergency room. So he's now reduced. Will you just follow him up in your clinic, make sure everything goes well? So let's see the next slide there, Pankaj. So looking at the injury films, Sudhir, is there anything confused? This is the injury film he came to ED before they reduced it. It looks like, like a dorsal dislocation kind of thing. Are you concerned about anything?
Yeah, I think the radial side articular surface doesn't look too good. And these fragments of bone obviously tell you that the story is a little more than just a pure dislocation. And that articular surface looks like it probably flipped in the back.
Okay. So they did a reduction in emergency room. So he's come to me in the clinic a day later. Let's click on that. Pankaj. Yeah, there we are. So that's his reduction film now. So there he's swollen and stiff, so he's not moving very well. Do you have any?
He's still subluxed dorsally. I mean, it looks like the volar plate probably has come off as well. So it doesn't look very stable, and that fragment at the back still worries me. I still want to know where that came from.
Okay. Hemant, anything to add?
Can you show the next one?
That's it. We don't have any. We have nothing. This is it. Chai, any thoughts?
Yeah, I think the writing is on the wall on your first X-ray.
Let's go back to the first
X-ray.
one.
Yeah. Look at the dorsal swelling at the base of P2. That tells you there's a central tendon avulsion. That bony fragment is a partial avulsion at least of the central tendon. So.
Yeah, I thought so too, Chai, but I was confused because with the dorsal dislocation, there is no business for the central slip to come off, right? In fact, his volar side is pulled off, right? So I'm thinking he's probably torn his radial collateral, as Sudhir pointed out, right? And then I'm looking at it and saying his volar plate has come off. So why would the central slip come off, correct? So I was like, I'm not so sure, right? Whether it's central slip or whether it is the articular surface or something like that, right? So next slide, please. So what do we do now, Sudhir? Your thinking is articular surface. Do you feel you want to shotgun it? Chai is thinking maybe dorsal fragment of extensor tendon. How should we approach this thing? It's a closed injury.
Yeah, very, very tricky what approach to take in this. I would probably get an MRI to help me out, or maybe a CT scan would help me out to tell me a little bit more, but of course it will be very confusing.
Yeah, I did nothing. I mean, and he said his son, I have to do this quickly, so I did not.
I'm a little worried about opening it. Do one thing. I do clinically. I would examine his. I know it's painful, but I'd try and examine his extension at the PIP joint to see whether he's, showing signs that he has an intact central slip. If that is so, I'd just.
So there he's resting in this position where his finger is straight and he can't bend it very well. So his extensor looks okay because he's extending it. He can't bend it much. And when you examine him, his radial collateral is quite unstable. Hemant, you have thoughts?
Yeah, you're pushing it to the radial side, huh?
Yeah, I don't think this is from the extensor side. This is from the lateral or the radial side or the volar side here. This is not an extensor piece. We would probably go for a traction view or a CT scan. I don't think MRI will help too much in this.
I think a CT would have been good, but I didn't do a CT. Chai, any thoughts on where you might approach it?
Yeah, when I look at the PAV on this, right, the density of the subchondral plate on the radial side is very different from the density of the subchondral plate on the ulnar side. That's why it makes me think this is from the dorsal aspect.
Okay. So Pankaj has seen it, so I'm not asking him because he's seen it. So anyway, I went mid-lateral because I was like, heck, if it's a dorsal piece, I'll get at it. If it's a volar piece, I'll get at it, right? And the collateral ligament was unstable, which is why I was saying, he opens there already. So I just went ahead and did a mid-lateral, and actually the finger literally fell open like a book because the ligament was so unstable, right? And if you click on next there, Pankaj, so you can see that collateral hanging off. It's come off right from there and it's hanging off on the base. And then I'm looking to see, and the whole articular surface is gone. And so then we have to fish for that articular surface, which is now floated in the free space under the extensor tendon. So we're looking for it and then managed to find it. It's quite big, right? Almost the entire articular surface of that phalanx, middle phalanx, is off. It had a small piece of bone. And so I was able to put these 2K wires from volar, bring them out on the skin dorsally. And you know, the pressure of reducing the joint held it in place. So just repaired the collateral with an anchor. He never really came back for follow-up like every 17-year-old boy until I caught him in the corridor of the hospital one day when he came to see his mom and took that photo to see his final range. So we took out his wires at 3 weeks in the clinic, and he moved, and he was 17, so he got back a pretty good range of motion. So I think with some of these injuries, you got to be careful that the whole articular surface can fall off.
Yeah.
And I think this mid-lateral approach is handy. If a collateral ligament is already gone, you get a nice open book kind of approach to the whole thing. A little different case, yeah.
How do you fix the fragments with these wires? I mean, it looked like a very just the piece of the articular surface with not too much bone.
Yeah, there was the tiniest bone, Sudhir, so I could put these 2.8 wires across and coming up the dorsum. And I think part of the thing that held the joint in place was the fact that once you reduce the joint, the fragment is compressed, right, from the congruity. So I think it's a bit of both. Yeah, for sure. Jesse Jupiter wrote a paper of putting histocril glue, a dermabond on the, I'm not so sure I would do that. I don't know if it'll interfere with cartilage healing, you know, being an acrylate. So I think the pressure of the joint generally is good enough to hold it.
Yeah, I did once use a monocryl suture.
Okay.
And left a part of it in the joint,
Yeah.
thinking that it's going to get absorbed over a period of time, and we get him moving, it'll probably fray off.
Yeah.
And he did fairly well.
Yeah. The other thing I've done sometimes is put a trans-articular wire skewering seek kebab of the articular piece and put a wire across, and that holds it stable. And then you can pull that pin out. And by then, you know, by about between 2 and 3 weeks, and then should be reasonably stuck down as well. Thanks, Pankaj.
Yeah, great
Thank you,
case.
sir. Shall I go on to the next case?
Yes, please.
Yeah.
So the second case is this young adult, dominant hand, 18 months post-trauma and a fibrous ankylosis. Any thoughts?
Pankaj, which finger is it?
I think it is the middle finger. It is the middle finger.
Occupation?
He's just he's a student. He's 19, 20 years old.
I think a lot depends, Pankaj, on whether he's got pain, whether movement is critical. It's funny, you know, a few years ago, I had a plastic surgery fellow. My hand fellow was plastic surgeon. And he'd had this fused many years ago when he was 17, football injury. And I used to call him in the room and say, look, he's got a fused finger and he's working fine. He's a surgeon. He's doing great surgery. And, you know, a lot of times, especially index finger, for example, I tend to say, you know what, if it's painful, I can fuse it. You'll be functional. So I often give them that option at the beginning. I may be too radical, but I think it's good for them to know there is an option to just have it stiffened and carry on with their life if it's not a big impediment for them.
Most of these youngsters, I think they seek treatment when they realize that they can't ride their bikes very well with a stiff finger.
Sure.
That's when they start seeking the treatment. It's quite a craze in India. Any thoughts? Yeah.
You mentioned that it's a fibrous ankylosis, so there's not much movement there.
No, there's just a forced couple of degrees of jog of motion.
Yeah, I'm just thinking that maybe the cartilage on the proximal phalanx head would dictate what I would do on table. Because if it's a fibrous ankylosis, he hasn't been eroding it and causing too much damage. Maybe a good arthrolysis after a shotgun approach, and then make my decision whether I'm going to do a volar plate arthroplasty or a Hemi-hamate for this one.
Yeah,
So it's 18 months.
yeah, that's an important point that you made out, sir. My observation has been and who have not exercised much, they have a much better cartilage than those who have tried too much during that phase.
A lot of times they put through physiotherapy, which just keeps on. It's grating the surface, and you tell them stop this, but they still go back to physiotherapy, and that really destroys the head. And I'm struggling with with a patient who keeps coming back to me because his head has now become almost half the size, and the joint has become unstable, and he's still at physiotherapy, and he just desperately wants to go back to playing his sport.
So
You mean he has lost his head?
I'm losing mine.
So this is what was done. I did a hemi-hamate arthroplasty for this patient. I could mobilize the joint completely, and if I got good soft tissue release and the ankylosis could be released, since the major chunk was going to be the new articular surface, I thought I would give him a chance with whatever range of motion. He's about 8 weeks when this photograph was taken. So hopefully we'll get a better range of motion as I start working on it. Shall we go on to the, yes?
What would you do if you found the head of the proximal phalanx totally destroyed or not good at all? Suppose you opened it for hemi-hamate and you find that the head of the proximal phalanx is not good.
Yeah, not good. I more often than not, I see them abraded. I've very rarely seen a pristine P1 head, and I have gone ahead and done a hemi-hamate without any regret.
Oh, okay.
What you see in the long run with these is that they tend to have a little bit of crepitus and some pain in loading them beyond a certain point. But day-to-day activities of daily living, usually they're quite okay. But the moment they want to do something with a little more force, they do complain of discomfort, and they keep coming back years later telling you that there's something wrong. And if you can feel crepitus sometimes, and you have nothing else to offer them actually.
Yeah,
you can fuse them now or fuse them later. They'll get fused at one point.
Pankaj and Randy, what about silastic implant replacement in these cases?
Sir, every other option that is present would perhaps not be as durable as a hemi-hamate. And if you are forced to do an arthrodesis or a replacement, it can always be done. So we are not burning any bridges here.
Okay, fine.
Even silicone lasts only 5 to 7 years. So I don't like silicone in young people.
And sorry, this was the index finger and not the middle finger. I'm sorry.
Yeah, so for me, fusion would still have been the #1 salvage. The the two-piece pyrocarbon or other implants are a little bit better, but in a situation like this, they end up unstable and subluxate as well because the collaterals are no longer in the right position. So it's very hard to replace these without using silicone, but silicone doesn't last long. So I would still fuse this guy from the beginning, being index finger.
In fact, if I may share my experiences, silicone implant, I have seen most of them breaking about 5 years later. The hinge which is there breaks off. But then what has happened is that the surface on the proximal phalanx and the middle phalanx remains intact with a soft tissue and capsular cover. They do very well. They do very well. I've got a 20-year follow-up of a patient whose implant is broken inside and he's absolutely comfortable. Because the silastic surfaces are rubbing against each other and there's no problem.
Yeah, the principle is the encapsulation of the silicone implant. So once there's good encapsulation, depending on how strongly he uses it with rotary forces and things like that, I suppose some amount of movement without pain will persist. But when it's unstable, obviously you need to then think in terms of fusing him or doing something else.
Shai, what are your thoughts on index finger, PIP joint?
Yeah, I mean, I would have, I think Pankaj is brave. At 18 months, I have some significant concerns about the integrity of the articular cartilage on the head of P1. And even though it may look good, it's articular cartilage that's not been loaded for 18 months. And therefore, it's not going to be durable. Articular cartilage relies on the principle of loading. So it may look good, but it's not going to work good. So it's going to break down inevitably. So I agree with Randeep that I would have been tempted to have thought of this more as an arthrodesis straight off the bat if he had significant pain. If he didn't have pain, and that was his fibrous ankylosis, there's no harm in leaving him alone until such a point in time that he has pain. And in terms of what Hemant said about silastic arthroplasties, there's enough data to show that even though they break radiographically, they still function reasonably well as spacers. So just the fact that they're broken doesn't bother me one little bit. But I would not do a silastic arthroplasty on an index PIP, although data from Mayo suggests that it is okay.
You all. Shall we move on to the next case? This was an adult male, dominant hand, fresh trauma to the ring finger. Any thoughts, Dr. Patankar?
Fresh trauma,
Yes.
I would do a close reduction and
Okay.
maintain it in flexion for about 2 weeks and mobilize him.
Okay.
You put this here. That means I want a good AP view here.
Pardon?
I'm not
No, no,
sure I have a good VP here.
Yeah, he's put this up for discussion, which means there's a trick to this. There's a googly in this.
No, sir. No, sir. I'm not that gifted to put googlies. Yeah.
Okay.
So any other thoughts, Professor Bindra, Dr. Mugdal, Dr. Warrior?
I think I like the extension blocking pin. So as Hemant said, first do a close reduction. It looks like the fragment is small, right, Pankaj? Unless I'm missing something, it looks like
No,
a
sir.
20%, 10%
yeah.
piece, right?
It's not hiding anything. It is what it is. Yeah.
Yeah.
So he was put in an extension block splint. This is what I use. Does anybody use this? Okay.
It's innovative and nice here, but no, I haven't used it.
It's really clever. It looks really good. Yeah.
This I had not put, by the way, but yeah. So this is the presentation that we had. It was still dislocated. Any thoughts why it was still dislocated?
I think he's extended, right? He's a
Yeah,
bit
it's
too
not flexed at all. It's just the dorsal skin that looks like it's flexed.
Yeah, so it was perhaps an
So-
inadequate extension block. Then he was simply put on a better extension block and the joint reduced.
Yeah.
Anything else? Anybody else would have done
I would like
anything?
I generally use skin traction with rubber bands.
Okay. Okay, so that's another
That's
option.
more durable.
Extension block wiring is an option.
Yeah.
Yeah,
Yeah,
the
and-
important thing is to keep, if you're doing anything that's not putting in any wires and you're using different techniques of blocking the extension without implants, then it's always good to keep checking on the further active movements with your finger, like holding the sides and feeling whether there's any crepitus or not. So you know that the joint is congruent and it's gliding, and that there's no hinged flexion happening. So it's important to do that. And of course, x-rays every week to see whether he remains in that good position for the first 3 weeks at least.
Absolutely.
Absolutely.
So that is what was done for this patient, and early complete flexion was achieved.
That's why I
Case
like the
4.
extension blocking pin. I think Pankaj, you showed a case that got infected, right? Those extension blocking pins, they can be a double-edged sword, but generally, once you put the pin in, you don't have to worry about redislocation, right? But the synovial fistula can be a problem. So I think pulling them out quickly is the key there.
Yes.
For sure.
Yeah, I think that was a learning point for me. Otherwise, I would pull them out at between 4 and 6 weeks, and usually land up in problem.
No,
So-
Pankaj,
Yes.
when you have this dorsal V sign,
Yes.
the temptation is to think about flexing the joint more If you look at the pre-reduction radiographs on the lateral view, the temptation is that you want to flex it more. I would counter that by saying that it's actually volar translation of P2 on P1 that is more critical.
Yes.
The P2 has translated dorsally. So flexion will only make it hinge and make you seem like you got a good reduction. The translation is what is critical, in my opinion. So I translate them and I use a transarticular pin. Unlike Randeep, I don't use a blocking pin, but the same principle, I use a transarticular pin, and we published our data on that. And it seems to work quite well. So that would have been my procedure of choice. I don't rely on these because I don't trust patients with this injury. So I put a pin across the joint and it's about 30 to 40 degrees flexed. I leave it for 3 weeks and then pull it.
Okay. Thank you,
Okay,
Dr.
Pankaj, we have only 5 minutes before the BOS announcement. So can I read
Perfect.
out the questions from YouTube
Yeah.
to all of you?
Can I quickly finish this case?
We have only 4 minutes then, after which we'll have to have BOS announcements. So if you can answer the audience YouTube questions, because they have
Okay.
no other way to access you, then
Yeah.
time permitting, we can go on to the case. So the
Yeah,
question is for,
sorry, go ahead.
question is for Neeraj, from Neeraj Bijlani to you. Would
Yes.
you use a Kapner splint to get back extension, and when would you use it? I think this is related to your previous case.
Yes, I would almost always use a Kapner splint, and it will usually be sometime around 8 to 10 weeks after my surgery, not before that.
Okay. And then there's a question from Dr. Tushar Agarwal. Does the fixed flexion deformity stretch out in the hemi-hamate?
It does, but I warn my patients that they may not get complete extension, and a 10-degree flexion deformity is more of a rule than exception. But in the beginning, I do not try to stretch out the flexion deformity, not for first 8 to 10 weeks. Only when they have started, they've healed well, I start stretching out the flexion deformity in a Kapner.
Okay, then Dr. Hule has asked, what about joint replacement? I think Dr. Patankar already asked you that question. In case you want to add something here.
Not really. As long as there is a possibility of restoring the articular surface and giving a penless mobility to the joint, we should do that. By doing that, we do not burn any bridges, and joint replacement can always be an option later.
Okay, and the last question is from Dr. Gerard Gonsalves. How do you fix the hemi-hamate graft? Can you use K-wires or always you use screws? Have you faced any complications regarding non-union when using K-wires?
I have never used K-wires. K-wires should not be used to fix a hemi-hamate graft unless you, as Dr. Mudgal said, you could use fully threaded K-wires. But I would use screws. We're using a lag principle. I over drill the hemi-hamate graft and compress the fragments. And since I have not used K-wires, I do not know the complications associated with K-wires.
I think the procedure is not described with K-wires. I think it would be wrong to use K-wires because you want to start early flexion. And I've had, even with screws that haven't crossed the far side, I've had, while I'm trying to reduce it, I've had them come off. So I think it's important to use good screws and get a good fixation. And as you mentioned, 2 but 3 screws are always better. So if you have a nice sized graft, it's good to use 3 screws.
I think it's reasonable to say that you use K-wires as provisional fixation. You don't need to drill anything. You use 0.035 or 0.028 K-wires, which is 1 millimeter K-wires or 0.8 millimeter K-wires, and you put 2 of them in, and you check your radiograph. And if it looks good, you merely take out one and replace it with a screw. You don't need to do any drilling. So that's the only role I see for smooth K-wires. I use threaded K-wires as augmentative devices.
Unless you comminute the dorsal cortex, which happened to me recently, then it's a situation.
Yeah.
And then it's a salvage with K-wires and a cerclage wire and everything else, because we shattered the dorsal cortex because all the volar screws converged too close to the center, right? And then it broke, as Pankaj pointed out, because it's chronic, you're dislocating it. So the dorsal bone is already soft. You don't direct your screws correctly. You go a bit too central. Suddenly you got a hole there. Then you have to look at other techniques.
Yes.
Things don't always go well.
Yeah, I had one while doing a shotgunning, the dorsal cortex actually cracked. And I didn't realize that until I tried to put it back in and the whole thing came apart. So we had to rely on, I changed to a plate and with an extra K-wire from the dorsum.
Okay.
So that's been excellent, gentlemen. I think lots and lots of tips and tricks and great learning in the first 2 sessions. So as is customary, now we go ahead with the break and the BOS announcements. The break as in the break from academics and listening to BOS announcements, and then we come right back to session 3.
A very good morning to all the viewers of this webinar and to the faculty as well. On behalf of the Bombay Orthopedic Society, I thank all the faculty, international, national, as well as local faculty for participating in this last flagship meeting of the Bombay Orthopedic Society for the academic year 2021 and 22. As we come to the end of this academic year, we are yet to have our conference, which is WIROC. This year, WIROC is probably on the largest scale you've ever seen. It's going to be called WIROC Global. It is a conference which will never sleep. You are going to have sessions during the day. You're going to have recorded sessions during the evenings, along with a fantastic academic program made by the 2 dynamic secretaries, Dr. Vishal Kunnani and Dr. Ashok Sham. On behalf of the Bombay Orthopedic Society, I welcome all of you to WIROC Global, and I hope that all of us will interact physically in the conference and have memories to share for a lifetime. Kindly register for this conference as soon as possible. Residential registrations are still available, but before they get completely over, I would request those of you who wish to get registrations and residential registrations, kindly register immediately. Registrations will be open for the next 1 week or so, but if you're overflowing with registrations, we may have to stop the residential and non-residential registrations. Hence, register fast and do not miss this meeting. This promises to be the biggest academic extravaganza for this academic year. Thank you very much, and thanks all the members for supporting the BOS in all its endeavors. Over to Dr. Rajuna Mehta again.
Yeah, thank you, Swapnil. I think we are really going right on time, and this is great. For the next session, may I re-invite Dr. Sudhir Warrior to take over the proceedings, but a short announcement before that to all the faculty. There's a little bit of a 2-minute lag between what you all are presenting here on Zoom and what we are interacting versus the YouTube. So it takes a bit longer for the questions to come in. So I'll keep a watch on the YouTube tracks, but please do wait and let that audience interact with you, because that's the only way they can get answers from you. Yes. So Dr. Warrior, back to you again for another 2 more exciting sessions. The ones which are actually going to show you what's new in hand surgery. Dr. Warrior, please.
Thanks, Rujuta. And we've seen how newer implants, plates, and screws, and techniques, and small surgical procedures have changed what we did, some years ago. But along with that, when we joined hand surgery, microsurgery was in its infancy in the country, so to speak. And over the years, there's been such rapid changes that the possibilities have just completely changed. And to tell us something about all of that, I have a presentation from Dr. Samir Kumta, who unfortunately is at a place where he may not be able to get a good signal. So on his behalf, I'm going to play his video. A very good day to all the participants in this BOS Master Series on the hand. And many thanks to Dr. Rujuta Mehta.
The audio is a little low, Dr. Warrior.
Yeah?
The audio is very low. Is there a way of increasing the volume?
Surgery in the hand, not just flaps. So
Yeah,
here I
better,
have
better.
all the various applications of microsurgery in the hand. And some of these are well known to all of you: replantations, revascularizations, repairs of nerves, toe to hand transfers. But many that are not so well known, or that microsurgery is not thought of as an answer to, I will focus on in this talk. So we all know the use of microscopes for repair of blood vessels and nerves, but the use of an operating microscope to improve the quality of dissection and to protect vital structures in the hand is not so often paid attention to. And some of the conditions in which this is really useful and vital, in fact, is in the release of difficult Dupuytren's contractures, particularly the recurrent ones, vascular malformations, hand tumors, and even small things like nail bed repairs and grafts. So here is a patient with a difficult Dupuytren's contracture, previously operated once, and the contracture recurred. And the microscope was used to identify vital structures, free them from the contractural bands, which are thoroughly excised while protecting the vital structures. And this ensured completeness of the release, which you can see in the late post-op result. Small thing like a nail bed defect, a young girl who wished to have good normal nails, a nail in her index finger. And many of these patients are just left alone. You have to live without a nail. But this girl insisted that she wanted a nail. So a small, very thin nail bed graft was harvested from the great toe using the microscope. And the graft was matched to the size and shape of the nail on the index finger and was placed over the nail having grown as a donor and recipient cells. And the girl is now able to show her painted nails and is very happy. Flaps for traumatic skin loss are also well established. All of you know about them. But there are some difficult situations where you cannot do without free flaps. In fact, free flaps are priceless in such situations. And some of the cases, difficult situations we've come across are with scleroderma and with difficult contractures in young children with Wilson's disease, in contractures following electric burns, and of course in pulmonary ischemic contractures. Now here is a medical student. Currently, Ukraine is in the news. This boy is a medical student in its neighboring country, Belarus. And he had a patch of scleroderma with a very difficult contracture across the elbow. The release of contracture entailed going all the way down to the elbow joint and in fact releasing the capsule of the elbow as well. The only thing that limited our achieving full extension was the tightness of the nerves and blood vessels. So any further stitching meant reduced flow in the brachial artery. So we had to stop at this. But here the bone and joint as well as the nerves and vital structures are all exposed and we couldn't do with just a skin graft. So we had to put a flap which he took from the middle thigh. This was the posterior middle thigh flap as a microarticular flap. And here is the flap placed, and this is a late post-op result which patient sent from his medical college in Belarus. Difficult first web contractures also with scars and with malunions of metacarpals and other issues where multiple problems have to be treated in the hand, which is already scarred badly. And this whole scar can be replaced, the contracture released, and surgery on underlying structures can be done if you use a good free flap. And this is a video showing excellent functional recovery and a good cosmetic result as well, following thigh flap placed on the dorsum of the hand and used also to release the first web. And you can see how well the flap is merged with the surrounding tissue. Another useful application of flaps in difficult or complicated traumatic injuries where there is also a negative flap here, where there is skin loss, there is a discontinuity of the radial and ulnar arteries, the nerves, as well as tendons. And not just skin, but all the vital structures need to be replaced. There was a gap in the radial artery. So the artery had to be bridged with the graft. So we killed two birds with one stone in a way by using a flow-through free flap. This is an anterolateral thigh flap with the descending branch of the lateral circumflex femoral artery. The artery was used to bridge the gap in the radial artery, and the flap was used to cover the defect after repairing the tendons and nerves. And this was the result, an excellent functional result as well. A patient treated with a anterolateral thigh flap for the dorsum following treatment of the very bad infection. Another application of microsurgery in the hand, which is not commonly thought of or used, is the use of functioning muscle transfers. This was a young boy with very bad compartment syndrome, closed fracture of the lower end of the radius, ulnar, treated with a tight plaster, which was ignored for 4 days and resulting in necrosis of the entire forearm skin and soft tissues, and sequestration of the bones as well. So this boy needed multiple surgeries over the next 5 years with debridement, sequestrectomy, vacuum treatment, skin grafting, wrist fusion, and finally, when we had a fairly good healing and a good position of the bones, which had yielded, we took him up for surgery. We dissected the forearm. We found the stumps of the median nerve, and we put grafts to repair the median nerve. We fused the wrist with a long plate, and that plate functioning gracilis muscle flap with the skin island, and the nerve to the gracilis was joined to a branch of the to the anterior interosseous branch of the median nerve. And this boy required surgeries after that for tenolysis, contracture release. Then he disappeared for nearly 10 years, and now he was 5 years old when we started treatment. Suddenly appeared a few weeks back to see Dr. Warrior, and he's 18 years old now, and fairly good flexion in the hand because of the function of the gracilis. Microsurgery also is extremely useful in treating difficult non-unions. This is such as failed bone grafting following failed Elizarov, infective non-unions. We have used the vascularized fibula on several occasions in the upper limb to treat these difficult non-unions. Here is a 42-year-old lady with no comorbidities, came with a closed injury, fractures of the radius and ulna, treated by plating, following which he developed fever, raised counts, wound game. Secondary suturing was done, but the fever continued. Finally progressed to severe osteomyelitis, leading to sequestration of both radius and ulna. This was converted to an external fixator. The plates were removed. And then finally, our dear friend, Dr. Mangal Pariyar, took over, and he did a thorough sequestrectomy, placed vancomycin beads and collagen beads inside, did an internal nailing, thorough debridement. And when everything was quiet, all the infection was controlled, we planned a scar excision and a replacement of the gap in the bone with the fibula. Now, because there was a gap in both radius and ulna which had to be bridged, we took a single fibula with an island of skin. We took out a small segment in the center of the fibula, which allowed us to bend the fibula with a small loop in the pedicle, which was placed without kinking. And both segments of the fibula were used, one to replace the ulna, or to replace the gap in the radius, as shown in this picture. and both were then plated. This was the double barrel fibula, as we call it, with a skin island. This was one segment, another segment, and central segment was removed. And this is the plate. And here is the skin sutured in place, the vascular anastomos. And this is an early X-ray. And then she went on progress to rapid union within 6 to 8 months, and with excellent function at the end of a year. Another example of bony reconstruction in a long bone gap. This is a 28-year-old male with a fracture of the humerus, which was operated 4 times by another surgeon. Persistent non-union with avascular bone in the center. Need excision of the bone, freshening of bone ends, and replacement with vascular edge bone because the resulting bone gap was quite big. So we used the help of computer-aided planning and reconstruction and 3D printing. So we printed a model of the humerus. We planned the segments to be accurately measured, the gap, prepared cutting guides to cut the fibula to the exact length required, and also got a 3D printed customized plate to fit onto the fibula and the humerus on either side. And then this was vascular fibula was done, and this is the union progressing well. And after you see the pictures on the left, after a year, the fracture is united completely. Now, small bones also sometimes go into non-union, and other than non-vascular bone graft, there's hardly anything that can be done. And if that also fails, and this is a typical example is in the scaphoid, where the fracture going into non-union also has an element of avascular necrosis, particularly in the proximal pole. So normal bone, ordinary bone grafts often do not work, and there is a recurrence of non-union after treatment. So when faced with such situation, we have used a small vascular and bone graft from the medial femoral condyle, which has proved extremely useful for treating non-unions in small bones anywhere in the body, and it has tremendous application now all over the body, from the larynx to the small bones of the foot. And so this is non-union of the scaphoid. You can see the gap has been exposed, and a small graft from the medial femoral condyle was taken along with its blood vessels, which were anastomosed to the radial artery and navel vein in the wrist, at the wrist, and the graft was placed in the gap and fixed with the wires. And this is another patient where the graft was fixed with the screw, and that is united very well. Now, this is one patient with an unusual situation. This is a corticocancellous graft with the KY used to treat a non-union of the scaphoid. And at the end of 1 year, the entire proximal pole has undergone avascular necrosis with fragmentation of the pole. So, yes, not just the medial femoral condyle, we took it from a different part of the condyle, where we could include part of the articular cartilage of the knee from a non-weight bearing area. So and did a 3D printed model of the proximal pole of the scaphoid by mirroring the normal opposite side. And then we carved the graft to match the exact dimensions of the avascular pole that had to be replaced. And then we just removed the avascular pole completely and replaced it with this graft and fixed it with the help of 2 pins. And here the bone is united nicely. The cartilage is thicker than the resident cartilage of the scaphoid because this cartilage has come from the knee. And this is led to pain-free good function in the wrist. And the donor side from where we take the graft in the middle aspect of the lower end of the thigh, we allow patients full weight bearing after immobilizing for 2 weeks, and they have full return of painless movement by about 2 weeks. So to conclude, the microscope gives us better illumination and magnification. Therefore, we can visualize the pathology and the vital structures better. And because we can see better, we can repair and reconstruct better. And this naturally leads to better results. So today, I think microsurgery is an inseparable part of hand surgery and is something that everybody to some extent or the other needs to get the hang of, so that the quality of your surgery can improve. Thank you very much. And I must thank my dear friend, Dr. Sudhir Warrior, for he has been involved in all the cases that I've shown. Dr. Leena Jain, my colleague, a plastic surgeon, she's also been involved in most of these cases. Dr. Mangal Pariyar, again a dear friend who's been involved with many of the major long bone cases where we did vascular bone grafts, and Dr. Alex, who lived with the fractured humerus. So thank you all. Unfortunately, I am traveling to a remote area during the time that this master course is taking place. So I think in my absence, Dr. Sudhir Warrior will be happy to answer all questions that you have regarding my talk. Thank you very much.
That was really fantastic. Through some of the most difficult problems in the upper limb, and he's been involved in doing that for the lower limbs as well. Really, some of the most what I take out of that is that there are certain cases where 5, 6, and 7 procedures were done before seeking the plastic surgeon's opinion. And I think there's so many solutions that a good creative plastic surgeon can bring in to help healing and bringing back these patients to good function. So this was just an idea to try and show all of the possibilities that are out there. Now I'm going to take the next talk, and it is on a similar kind of advance that was at one time probably not even in the back of our minds. And in this case, I'm presenting it on behalf of Dr. Manish Agarwal, whom we all know very well. He's one of those leading edge advancing orthopedic onco surgeon. And Dr. Amrish Baliar Singh, who was the head of plastic surgery in Nair and works in Bombay Hospital and Hinduja Hospital. Absolutely fantastic microvascular and plastic surgeon, and a very, very wonderful person to team up with. And Dr. Nikita Shetty, who's been working with me for 5 years now. So on their behalf, I'm going to present this lady doctor who came to us with a swelling in February 2020. She had occasional pain, mild restriction of mobility, and just an incidental X-ray showed this. And this was in Feb 2020. She saw me and Manish as well. And we discussed various options then. And she was quite happy not to do anything at that time. And she went away and came back in August. And this was her 3D CT in August. Again, she met me and Manish. We further discussed what options we had. And she chose not to pursue a surgical solution. She was still able to do most of her duties with some discomfort. So at this stage, again, she went away, only to return in 2021 with severe pain and restriction of motion, with a large bump on the back of the hand, and now unable to do any work with lots of pain and very uncomfortable. So at this stage, there was obviously a progress that was causing the discomfort to keep increasing. And this is what we could see now, that the entire head was completely destroyed and there was no joint to speak of. And this is her MRI that shows that it is a large tumor which is encapsulated there, but completely destroying the head with no articular surface, and salvage now was impossible. So what were the options? And one of the options that I first discussed with her at this stage was a reamputation. And she flatly refused and said, no, I don't want a reamputation. I want my finger. And I told her, well, why don't you consider a reamputation? And I showed her pictures of some of my older cases. And I said, you can barely make out, if you look at the image on top, you can barely make out that something is wrong. And the function is excellent. And all of this in 3 to 4 weeks, you don't need to worry too much. She said, no, and she went away. So I discussed another innovative option that I learned from Dr. B.B. Joshi many, many years ago. And that was in a patient that I saw, a 55-year-old man who again wanted to have his index finger salvaged. So we retained the index finger. We knocked out the tumor and took out an iliac crest graft, which I like to call the pen drive iliac crest graft. It's a graft with two edges of cortical bone on both sides and a central part which has corticocancellous bone. And you fix that graft right here in between the two proximal phalanges after having excised the entire tumor and maintaining the tendons and the gliding structures intact. Fix that down with a couple of wires, and it's pegged into the proximal phalanx of the middle finger as well as that of the index finger, and it suspends the index finger now in space and allows the soft tissues to heal. And once that heals and the bone unites, you can get good function. There's always this worry that is it going to work, is it going to give trouble, etc. Here's another patient. Like I said, that patient was a farmhand and he went back to work. And I don't have his long-term follow-ups, but I had another occasion for another case, which is extremely similar to this one, and where I did exactly the same thing. And we use an external fixator here to hold the fingers in alignment while he could move the distal joints and his wrist. So we just have a small area of immobilization to maintain maximum function in the hand while this graft heals over 6 to 8 weeks. This is at 7 years that his X-ray shows that his graft is holding the index finger out and it hasn't collapsed, it hasn't angulated the middle finger out, and it hasn't angulated, and he's got absolutely fantastic painless function. He does everything with his hand. He can carry weights, and rather than try and test him for a dash score or what have you, I just shall present a screenshot from a conversation that I had with him some years ago. And that was, I told him, I need your pictures. And he said, anytime for you, sir, absolutely no pain. I'm playing badminton, cricket, and riding my scooter and driving my SUV too. So he's doing everything with no pain 7 years on. Well, coming back to our case, the young doctor said, no, I don't like that. So then we had to sit down and start discussing. And that's when we called Dr. Amrish Balyar Singh, and we thought of doing a microvascular toe joint transfer. This surgery has been around for a long time. And Dr. Kumta, Dr. Purohit, and myself, we've done a few cases in the past, and there were limitations. The limitations were because it was early times, and we were worried about skeletonizing our grafts, and also the methods of stabilization were not too good. So we failed to give the results that we thought we could give in those days, and we slowly moved away from it. So in our patient, what we did was a clear excision with clear margins, and once it came out, you could see that the size of the tumor was quite large, and that left a big void in the dorsum of the palm. At this stage, we cleared out the proximal phalanx, exposed most of the proximal phalanx till its distal end, cleared out the metacarpal base, cleared out enough space for us to now allow an implant to be received and retained with stable fixation. During this time, the microvascular team was harvesting the toe joint graft. So the second toe, metatarsophalangeal joint, is harvested on its blood vessels. Mostly, these blood vessels are on the dorsum from the dorsalis pedis, but in this case, as always, when you have something very difficult, it becomes a little more difficult because the plantar blood supply was more dominant and had to be dissected, and it took quite a long time, almost 4 hours, to dissect out the joint along with its blood vessels. This is what I mean by skeletonizing the graft, and you see there's only periosteum and its blood supply. Every other soft tissue has been taken out because you can't bulk up this area too much. So you need to actually pare it down to just the bare essentials and maintain the blood supply and So it takes a lot of dissection at that time. The next, once it's disconnected from here, you must remember that the toe joint, the metatarsophalangeal joint of the toe, normally has more extension, as 70 odd degrees of extension, and much lesser, almost half of flexion. Whereas when you want it on the MP joints, you want more of flexion and less of extension. So what you need to do is to flip this joint over. And once you flip the joint over, you can see that it now gives you the amount of adequate flexion that you need to make a fist. So you have to remember that and flip the joint over. Otherwise, you're going to have a stiff joint, a joint that won't flex enough. And the next advancement was the locking plates. So we had wonderful locking plates. We had the edge plate and a condylar plate to be to maintain the fixation strong enough to start early mobilization, to get very sturdy, strong fixation. And you need to understand that two ends require to heal, and that takes a long time. Sometimes with microvascular grafts, you see that it takes 3 to 4 months before there's enough union for you to put adequate force. So you need to be able to start rehab before that. And for that, you need an absolutely stable fixation, which the new Synthes variable angle locking hand plates gave us that option. At the end of 1 year, this is the follow-up we have for her. The bones have united, and that is her hand, and that's her function. That looks absolutely wonderful. She's painless and can do almost everything. You can see that the 60, 70 degrees of flexion that she has is the amount that the metatarsophalangeal joint can give. She's also got a very, very strong pinch. What about the donor side? The donor side is painless. The scar is large, of course, but it is a little floppy, if you can see. So there are ways of stabilizing it. This young lady obviously did not choose to get any of that done. So microvascular toe joint transfers, not a very common thing. In fact, I haven't heard of any other plastic surgeon using this in our country. Very infrequently done abroad as well. And it does have a definite indication in very high demand situations like this one. You can get excellent outcomes if you have the proper implants and if you have stuck to the principles of reconstruction. It obviously requires a very good team, very well coordinated team to get the good results. Especially the rehab team is probably the one that the patient depends upon for 4 to 5 months before you can get a good result. And the donor side morbidity is there, but it's not too significant. I'll stop sharing here. And if there are any questions, we can take that right now.
So the YouTube does not seem to have any as of now. Maybe you could discuss amongst yourselves.
Yeah, I mean the main purpose of bringing this into a master class was basically to expose as many people as possible to the possibilities that can help us in very, very difficult situations. Any comments from Hemant or Pankaj?
Sir, just one question, sir. Did you consider doing it as two-stage surgery or was this a one-stage surgery?
One-stage surgery.
So any risks in doing it one stage? I mean, this obviously was a giant cell tumor.
Mm-hmm. It was biopsied earlier. It was biopsied earlier. We had a diagnosis, and that's the reason why Manish was around.
Okay.
So that I didn't want to do the excision and then be to leave out something that should have been done. So we got him, and if you work with Manish, you know that it's so meticulous. It's unbelievably meticulous the way he does his work, and then each and every section they've it's such a organized this thing that you take sections from here, send it for frozen sections and confirm. So everyone takes a break while the frozen sections come in. These frozen sections are at different levels and different margins to tell you are clear from where. I mean, you are absolutely in the clear before you go ahead and do your reconstruction. So that's very, very important. Those principles are something that I think Ajay Puri and Manish Agarwal and the others now, Dr. Ashish Gulia and so Anchan and so many others are now following and doing great work around.
Thank you, sir.
How about microvascular PIP joint transfers?
We're just about coming to grips with this, but yes, there is some work on that as well, and maybe sometime in the future we should be able to because Hemant, as the earlier ones that we did with the fixation methods, I put the loop and the intramedullary, I mean the loop between the two fragments and an oblique wire, and we tried all sorts of things, and I think we did 3 of them and weren't very happy with what we had actually done. So now the fixation techniques are so good. The microvascular techniques obviously are excellent. And I think putting them together is what needs to be done.
Yeah, I suppose these locking plates will give you much better and further options.
Oh, yes, I'm sure they will. So it's the PIP joint. We're very eager to think in, think of other options that are there where we can use these techniques. Like the cartilaginous graft from the medial femoral condyle. The world is divided into people who don't want to do these grafts and those who think that this is the only way to go. So Heinz Berger and his team and the Mayo Group and all of that, they're doing a lot of work on this, while people like you are probably getting equally good results without the vascularized grafts. Your views on the proximal pole avascular necrosis. We have, I think, 2 or 3 minutes to discuss that. Hemant?
Yeah.
Proximal pole scaphoid avascular necrosis. Samir and I tend to take it to the other end, towards the microvascular end. You don't do that. You rely on...
Yeah, I rely on non-vascularized grafts. Recently, I've had a paper also being sent to me from Chai, who says there is no need for, unless there is a special indication, one should not go for vascularized bone graft or for proximal pole AVL. I think it should be done only for failures.
Right. In fact, that's the highlight of the paper that we published in the IJPS. I think 14 cases. And the highlight of that paper and how it differs from most of the world literature is the fact that we've only chosen failures or completely established avascular necrosis of very small proximal poles. So we reserve it only for that. Most of the others, obviously, the more conventional grafts are as good.
Not only that, even microvascular or even vascularized bone grafts, both of them are not necessary.
Absolutely. Yeah. Absolutely, because if you see the history of vascularized grafts, that's what we've seen, that initially there's a great enthusiasm like everything else, and then it slowly tapers down to crystallize its indications to those very small specific indications where it is absolutely essential.
Right.
Sir, I use vascularized as well as non-vascularized bone grafts with equal frequency. And for proximal poles, I tend to use vascularized. I have used for non-vascularized as well. Just, I feel the non-vascularized ones just heal a bit faster. Beyond that, it may not make much difference in the final outcome, but I'm able to mobilize these patients just maybe a couple of months earlier.
You mentioned the non-vascularized ones heal earlier.
No, vascularized ones heal a bit earlier.
Okay. Yeah, that is what even the paper that we published, the IJPS paper, says that we've got union in 14 weeks. When you look at other papers, they're 17 and 19 weeks and even beyond. So they do tend to heal a little faster. There was a lot of misgiving about those fibular grafts, which were, which we used in the lower limbs as well, the microvascular fibular grafts, that it doesn't unite at one end. You always have that worry. We've seen that time and again, that when you use microvascular fibular grafts, one end tends to heal very quickly. The other end takes forever, and your heart is in your mouth each time you take an X-ray every month, and you wait for 6, 8, 9, and 10 months sometimes before the other end unites. And the humor is that Samir had just shown exactly the same thing. One end just united in no time, and the other end has taken almost 8 months to unite. Right, I think.
Yeah, 11:50. So maybe we should move ahead with Dr. Bhatia's lecture first.
Yeah.
Yes, now it's my pleasure to introduce Dr. Anil Bhatia. I don't think, I think it's stupid for me to say that he doesn't require an introduction and things like that. But my point is of introducing him is to tell you that he is at the leading edge of brachial plexus research the world over. He's one of the most sought after brachial plexus surgeons, and is in every single world forum on brachial plexus injuries. And his life is dedicated to this. He knows the phone numbers of every single patient he's operated and the outcomes of over 1,500 or 2,000 or whatever number he has reached right now. Anil is just a fantastic, dedicated brachial plexus man who also, of course, does hand surgery. Anil, take it away.
Thank you, Sudhir, for the excellent workup that you've given me. It's not yet 1,500 or 2,000, but I hope to get there. Why am I not seeing my presentation?
Your video needs to be on so that you can share screen.
All right. Okay. Hang on. Oh dear. I don't. All right. Here we go. Now can you see my?
We can see you now. Now we need to you to share screen.
Okay.
Yes. Yes, it's on.
You can see my presentation on, right?
Yes, you can go full screen now.
Okay, right. So thank you, Sudhir, for the excellent support I've had from you over the years. My presentation will not be similar to the ones that I've heard earlier today. I'm going to take you along a journey of my evolution as a brachial plexus surgeon in the treatment of closed traction injuries or post-traumatic brachial plexus injuries. Experience over the last 3 decades with nerve transfers and nerve grafting techniques have allowed us to restore function in such a case of extended partial palsy, where there is a complete loss of abduction and external rotation of the shoulder, loss of elbow flexion, and loss of independent wrist dorsiflexion, where exploration confirms the presence of C5, C6, C7 avulsions. Dedicated nerve transfers for reinnervation of the rotator cuff, double fascicular nerve transfer for elbow flexion, a nerve transfer of the anterior interosseous nerve for the ECRB, and my own modification, 2 intercostals being transferred to the long thoracic nerve that would not otherwise recover, would restore this sort of control of the shoulder and the elbow. Excellent external rotation because of the innervation of the serratus anterior, and excellent independent wrist dorsiflexion, so that the patient is self-sufficient without need for any secondary surgery. However, if I look at my database, Sudhir, it is not yet 1,500, it's only 1,200 cases of post-traumatic palsies. Almost half my patients present with complete paralysis of the upper limb with a total disconnection of the brain and spinal cord from the upper limb, where any function restored would depend upon surgical endeavor. The steps in reconstruction have always been the same: detailed exploration to confirm the diagnosis, utilization of the available nerve donors, giving the biceps the priority, and after the nerve procedure has provided a useful outcome, the utility can be augmented by secondary orthopedic operations at a later stage. So use of the spinal accessory now to the rotator cuff and intercostal to musculocutaneous can provide such primitive function at the shoulder and elbow, which after a derotation or osteotomy of the humerus and a wrist and radial fusion can improve the placement of the limb in space and the ease of elbow flexion. However, if we want function distal to the elbow, the nerve donors adjacent extraplexural nerve donors do not suffice. We need an ipsilateral root stump that can be bridged to the median nerve with nerve grafts, like so, which would provide this type of result. The abduction coming from the spinal accessory transfer, elbow flexion, and pectoralis major from the intercostals, and the feeble finger flexion came from C5 nerve grafting to the median nerve. Please remember the word feeble. Following a derotation osteotomy of the humerus, wrist, and radial fusion, the placement of the limb in space has definitely improved. The range of finger flexion has improved to a very small extent. And she is able to utilize that control of the upper limb in some bimanual activities without actually using that finger flexion. When all roots are avulsed, we do not have an option. It is only the opposite uninjured brachial plexus that can donate a functioning nerve that can be bridged to the affected side. For a long time, I was enamored with the idea of using the Hemi-C7 bridge with long nerve graft cables for fear of sparking off a deficit in the only functioning upper limb that the patient had. But 13 years of experience with that technique, and this was the best I could achieve. In this 19-year-old, the shoulder and elbow came from the ipsilateral nerve transfers, but even at 5 years follow-up, the opposite Hemi-C7 had to be activated by a physical gesture in the uninjured upper limb in order to produce the feeble, absolutely useless finger flexion on the affected side. And the condition persisted even at 9 years follow-up. So till 2013, my Hemi-C7 transfer with nerve grafts was a useless procedure. And I chose to give it up. Now the hurdle of nerve grafting can be overcome only by direct approximation of the opposite C7 to the affected side lower trunk. We all know that for the full C7, when harvested, is going to make the distal function more consistent and stronger, as was shown in this paper by Tu. So when I adapted that is, I did nerve transfers of the shoulder and elbow, and I did a opposite C7 with nerve grafts to the lower trunk, the full C7. This was the sort of outcome I got. Again, 19-year-old, abduction coming from spinal accessory to suprascapular. The elbow flexion came from the opposite C7 via nerve grafts. And the wrist and finger flexion, very feeble, came from the opposite C7 with nerve grafts. But the patient was very dedicated. This was his improvement over the next 3 years. So the abduction improved, external rotation was regained, elbow flexion again became completely disconnected from the affected side, from the normal side. And the wrist fusion allowed me to get pulp to palm 0. The FCU to APB transfer got the thumb out of the way. Now, if you, as I said, if you want to overcome this hurdle of the nerve graft so that greater number of axons arrive at the distal target nerves at an earlier stage, we have to eliminate the nerve graft and connect the proximal functioning nerve to the distal nerve directly. For that, we would need to mobilize the nerve ends, reroute the nerves, sacrifice certain non-essential branches, position the upper limb in order to facilitate such a repair under tension, and if necessary, shorten the skeleton. All this we know, it is there in our Campbell, but application of this in closed traction injuries of the brachial plexus was considered a definite no-no. And this is the paradigm shift in my thinking that was demanded by this publication by, I'm sorry about this glitch. Yeah, here we go. This paper by Wang Shufeng from Beijing, who published in May 2013, that the lower trunk should be mobilized proximally by sacrificing the pectoral branches and separating out the posterior division. The full opposite C7 is brought by the shortest route, that is a pre-spinal route behind the esophagus across the neck for direct approximation. The medial cutaneous nerve of the forearm having been divided in the arm, being loose, and the growing axons can be harnessed for restoration of elbow flexion. An additional nerve graft cable was also provided along the same route. And the phrenic nerve was transferred to the posterior division of the lower trunk, so that a comprehensive strategy of restoration of abduction using the spinal accessory to suprascapular, elbow flexion from the opposite C7, elbow extension from the phrenic to the PDLT, finger flexion from the opposite C7 direct repair, and finger extension using the phrenic nerve once again. But that would involve entering into this jungle of the broken nerve ends lying in the medial aspect of the posterior triangle, dismantling all of that so that the upper, middle, and lower trunks could be isolated. Mobilization with sacrifice of the pectoral branches, and if necessary, humerus shortening of up to 3.5 centimeters and plating, so that a direct approximation was possible behind the esophagus in this awkward position. Now, all this seemed to provide prehension in Wong's series, which he published. He also showed that finger extension could be achieved by the phrenic nerve to the PDLT transfer. I was a skeptic. I could not believe these results when I saw them in May 2013 in Switzerland. So I decided to visit him in Beijing, taking my friends Piyush, the late Ashok Kaul, and Vitrag. This was I convinced myself about the technique, and this was the case I operated immediately after coming back in October 2013. The abduction external rotation coming from the rotator cuff, the elbow flexion without any action on the opposite side from the contralateral C7. Phrenic nerve to PDLT provided triceps. Following a wrist fusion, she was able to control finger flexion and finger extension using the transferred nerves with no significant gesture on the opposite side. And for the first time in my life, I was able to demonstrate manipulation of objects in space by the paralyzed upper limb in this manner. In the beginning, I was not able to achieve a direct repair in all cases. But I found there was a stark difference in the outcome when I did nerve grafting instead of direct repair. And the superiority of the outcomes that I achieved by direct repair, I published in 2017. So it encouraged me to continue with this endeavor of attempting direct repairs. This is a recent case I had operated in May 2020. The abduction came from the spinal accessory to suprascapular nerve transfer. Contralateral C7 contributed the elbow flexion. As you can see, there was no action on the opposite side in order to activate this elbow flexion. Wrist and finger flexion came from the opposite side. This video has been specifically taken to show that it is coming from the opposite side. However, and the phrenic nerve to the PDLT provided more than grade 2 function in the triceps. They already at less than 2 years, the patient can activate the biceps and wrist and finger flexion and yet keep the opposite upper limb in at any position and therefore do any other activity. Therefore, he is able to disconnect this from the donor nerve activity. Now, the same principle of mobilization of the lower trunk for direct approximation of the roots could be applied to ipsilateral ruptured roots stumps as well. This was a study I had contributed to along with Wang Chufeng. So this patient came with a flail upper limb following an accident. The untreated fracture of the upper end of the humerus dissuaded me from attempting a re-innervation of the rotator cuff. It seemed to be pointless. So I used the available C5, C6 ruptured root stumps in the neck for direct approximation to the anterior division of the lower trunk. The used for innervation of the posterior division. And the spinal accessory nerve was divided distal to the branches to the upper trapezius and bridged with a short nerve graft of 12 centimeters passed behind the clavicle to the musculocutaneous nerve. At 2 years and 3 months, he had regained elbow flexion from the spinal accessory to musculocutaneous. Of course, the shoulder was unstable. The rotator cuff had not been innervated. He had grade 3 triceps from the phrenic nerve to the PDLT transfer. And he had wrist and finger flexion from the ipsilateral C5, C6 roots. Since it was both the roots being contributing to the forearm flexors, the forearm flexion was fairly strong. Subsequently, I did a shoulder, wrist, and radioulnar fusion, and I transferred the flexor carpi ulnaris to the APB, and such an independent control of the upper limb with pulp to palm 0 could be achieved. So my current strategy is systematic exploration of the entire brachial plexus, innervation of the rotator cuff, and if that is not feasible, plan for a shoulder fusion at a later stage. It is a very good operation. Nerve transfers for elbow flexion and elbow extension. Since there is systematic exploration of the brachial plexus, we are going to find ruptured root stumps in more than 50% of cases. They can be harnessed for restoration of biceps or for finger flexion. If the C5 is used for the biceps, then one must try to innervate the forearm flexion using the contralateral C7 only with a direct repair. I will not do it with a nerve grafting. Of course, separate innervation of the posterior division of the lower trunk, mobilizing the lower trunk for direct approximation without separating the posterior division would direct axons in an opposite direction and therefore would hinder the eventual finger flexion. Therefore, PDLT must be innervated separately. And of course, secondary procedures have to be added to improve the utility of the restored functions. So this has been a struggle for the last 26 years. Since half my patients are flail limbs, I shall continue to struggle for better distal function. And I thank you all for your attention.
Thank you, Anil. That was, as usual, absolutely wonderful, because most of us are chaps who look at brachial plexus and say, refer it away or send it to the physiotherapist. But I think you put into perspective the fact that so much can be done to make them independent, to make them able to move that limb in space. And there are so many things that we don't think about, and get those patients to be able to do that. We'll come back at the end of this session for some discussion if we have the time. It's my proud privilege to now introduce Dr. Ashwin Lavande, who's who's an ace ultrasonologist, fabulous, fully, just like Anil, he's completely focused only on musculoskeletal ultrasound. And over the last 20 years, 15 to 20 years, I have just seen some of the most amazing images and some of the most beautiful drawings telling me how to go into the hand and what I'm going to find and how I can treat this, all of this, before I even go in. So to tell us about the Google Maps of hand surgery, ultrasound, Ashwin Lavande, who works in private practice at Dadar and is soon moving to his own place, I believe. He hasn't yet told me that. Ashwin.
Thank you, sir. Thank you for those kind words. And I still remember that time in 2004 when I had first come and met you, when you told me that let's start something new, and that is how we started this whole journey. Thanks to my boss, Dr. Mukund Joshi, who is no more, but he's still alive in our hearts and in our minds, who has always supported me and promoted me in this particular thing. So directly we go to the first case. So this is about a young surgeon who had a little finger injury, and he was not able to flex his little finger after it was locked inside the door when he was closing the door. So when we did the scan at the distal end of the finger on the volar aspect, what we see is that the FDP tendon, which inserts at the base of the distal phalanx here, is not seen. There is only an empty flexor sheath which is seen with an intact volar plate at the DIP joint there. So when we did the dynamic evaluation, we could see that there was a bony defect here at the place where the tendon had avulsed. There was a bony fragment lying here, and this is all the empty tendon sheath which is seen with no tendon tissue at all. So now we had to search for the tendon proximally. So then we scanned the PIP joint, and we saw that the volar plate at the PIP is intact. The superficial FDP tendon at the PIP joint is not seen, but the FDS lateral slips are intact, and the finger was moving at the MCP joint only because of the FDS intact tendon. So then we traced it proximally, and then we could see that there was a bony fragment with the retracted FDP stump lying around a centimeter distal to the MCP joint. This is the FDS tendon on top of the FDP, which has undergone retraction. And then as we scanned in the palm, we could see that the FDS tendon is still there, but the FDP has retracted and has retracted further in the palm. So then this was the information given. And then this is the post-operative pics. So it was confirmed that the FDP had retracted a little distal to the MCP joint with the bony fragment lying there. And then Dr. Warrior was able to pull out the tendon through underneath the A3 pulley up to the level of the middle phalanx. This basically was stuck just proximal to the A2 pulley level. And finally, it was sutured back with the proline sutures seen there. So ultrasound confirmed the findings. Second case is of a sharp object injury to the left thumb distal to the MCP joint. Now, what had happened was this particular gentleman had lost complete thumb flexion, and as you see this particular movie, you see that the distal stump of the FDP is still there. Passive dynamic movement can show the movement of the stump, but then proximally, there is complete empty FPL sheath through the thenar eminence. And now as we go into the palm, you see the FCR tendon there, and this is the retracted proximal stump of the FPL, which you can see in the palm, in the distal forearm. So with the help of ultrasound, we can tell the exact amount of retraction, whether it's in the finger, whether it's in the palm, or whether it's in the distal forearm. So this helps in planning the further course of action. After the tendon has been sutured, sometimes during aggressive physiotherapy, you feel a pop, and that is when we see that the tendon has given way, and you can see the sutures which are still there, but this is the distal stump, and the proximal stump has retracted all the way into the just distal to the MCP joint. And as you go further proximally, you can see the retracted FDP tendon showing a wavy appearance there in the palm, and that's the intact FDS tendon, which is still showing good function. Next, we go to the FDP flexor tendon zone 2 injury, where this is a sharp object injury where you can see the distal FDP stump there. The injury is at the level of the PIP joint. So the FDP tendon has undergone a complete tear, and the FDS tendon lateral slips have also undergone a partial thickness tear with feeble movements of the FDS, as you see here. And as you go, this is the proximal phalanx. This is the MCP joint where you see the retracted proximal stump of the FDP, which is lying here. And that's the intact FDS, which is still moving and showing some finger movements. So in such cases, we also have to see for the retraction in the palm and rule out that there is no second tear which is there proximally in cases where there is a long-standing history. So this is how we measure the gap between the tendon segments. That's the distal FDP stump, proximal FDP stump. So the gap is around 4 centimeters. And we also have a look at the palmaris longus tendon in the palm. And then this was an earlier pictures given to me by Dr. Warrior. And here he has reconstructed the pulleys and put an implant in cases where complete ruptures have happened. And this is how the implant is seen on the ultrasound. And what our job is to mark out the proximal and the distal ends of the implant. And then the surgery is planned by making incisions accordingly and putting the graft and railroading it through the complete area. So that's how the railroading happens. And then the graft is attached to the proximal end, and is sutured to the distal end at the distal phalanx level. So then we come to extensor tendon injuries. Sometimes the tendon is partially torn, is thickened, and at the site where it's inserting, there is a fracture. You can see the central band inserting at the base of the middle phalanx, and you see a small fracture there. The lateral bands are intact. So because it's not a complete tear, conservative management is done. But in other cases like this is the extensor tendon at the MCP joint. You see the tendon becomes thin, flat, divides into 3 slips. And at the level of the PIP joint here, there is a full thickness tear of the central band and one of the lateral bands. So when you do a dynamic evaluation here, you see that the gap increases as you do the flexion movement. That's the gap of the tear, and this is the intact lateral band on the other side. So in such cases, surgery is inevitable and the bands are sutured with the extensor expansion. So in some cases where healed fracture happens, finger rests in flexure or extension deformities and the patient is not able to flex it completely. So this patient was sent for a flexor tendon adhesion at the site of the fracture at the middle phalanx level. So this is at the MCP joint where the flexors are moving nicely. That's the A1 pulley. And as one goes distally, you can see at the PIP joint level also, both the tendons are seeing nice movements. This is at the level of the fracture where still the flexors are intact, the FDP showing good movements. So when flexor tendon adhesion was ruled out, but this patient had extensor tendon, this is the central slip at the base of the proximal phalanx, which was intact and moving normally, but the restriction of the flexion was secondary to the lateral bands, which are thickened and getting adherent at the dorsal aspect of the shaft of the middle phalanx. So this was the cause of restricted flexion and was conveyed to the surgeon accordingly, and tenolysis was done with good function accordingly. Then we have this distal radius fractures with the plates in C2, and this patient had a restricted thumb flexion with pain. So when an ultrasound was done, this is the FPL tendon in the palm, and when it was traced proximally into the distal forearm, you can actually see that as we go proximally, the tendon is showing some movements, but they are painful. You go further proximally into the distal forearm, and you actually see that the plate, the distal end of the radius plate is kind of splitting into the substance of the FPL, some fibers going posterior to it, some fibers going anterior to it. That's the FCR, and that's the plate going through and through the substance of the FPL, and that's why the tendon was kind of partially torn intrasubstance, and hence the painful thumb movement was there. And then you see in the other video that the FDP of the index finger and the median nerve are nicely sitting on top of the plate and are quite safe. So by ultrasound evaluation, you can say that the distal radius plate is kind of hampering the FPL tendon and leading it to a partial tear, whereas other tendons are still safe. So in such cases, the plate has to be removed and the tendon has to be repaired. That was the picture. Another case where similar distal radius plate is there, but extension movements were painful, thumb movements were painful, and you can see the tip of the screw going into the ECRB substance. Same patient, EPL is kind of, the undersurface of EPL is kind of rubbed by the pointed screw, and that's why the extension movements of the thumb were painful. Next, we come to the soft tissue masses. This was a middle-aged lady with a painless lump along the thenar eminence, and it was also protruding into the third intermetacarpal space dorsally. On the ultrasound, there was a large lipoma which was going in between along the thenar eminence, and these are all the flexors and the lumbricals, and this is the mass protruding through the third intermetacarpal space. The radial digital nerve of the index finger and the ulnar digital nerve of the thumb are lying on the volar aspect of the mass. The mass is splitting the two limbs of the adductor pollicis and is limited by the first dorsal interosseous to go on the dorsal aspect. And that's the mass protruding through between the third and the fourth metacarpals, lifting up the dorsal interosseous, and that's the extensor tendon to the ring finger lying on top of it. That's the dorsal interosseous between the second and third metacarpal, which is intact. So this was the diagram given, and accordingly the surgeon had planned the surgery, and thanks Dr. Patankar for sending me these wonderful images, and a wonderful surgery performed that time, and the entire mass removed. So this was like a nice roadmap to guide the surgeon accordingly. This is a middle-aged doc with a painless hard lump in the left thumb. And what you see here is, that's the FPL tendon. This is the nerve and the digital artery on the radial aspect of the thumb. This is the A2 pulley. And as you go, that's the hard mass, which is kind of a fibrous tissue, most likely a giant cell tumor with the nerve and the artery going around the volar aspect and lateral aspect of the mass. It was supplied by the radial digital artery, and this was the diagram given. So it was separate from the FPL and the radial neurovascular bundle, and these were the operative images. Thanks, Dr. Warrior, for making me understand all these particular small bits. That's the radial neurovascular bundle, and that's the mass. The mass has been excised with the groove of the nerve lying on top of the mass, and it turned out to be a giant cell tumor as reported. Another case where a young girl with painless soft swelling in the left middle finger, that was a lump, which was soft, compressible, and looking like a hemangioma or a slow flow vascular malformation. FDP tendon, the neurovascular bundle down there on the ulnar side, and that's the draining vein proximal to the lesion. And when you see this movie, you see that that's the lesion there, and that's the neurovascular bundle going deep to the mass. And then you see the supply, the multiple feeders. And one hallmark of hemangioma is when you compress and release on Doppler, the slow flow, soft, the colors, the vascular spaces fill up with color. So this is the hallmark of hemangioma, how we able to differentiate. And this is how we give the roadmap for the surgeon. That's the draining vein, the hemangioma, and this is the ulnar digital artery supplying the multiple feeders. And this is in the short axis. Then last few cases, severe pain along the ulnar nail bed. That's the movie where you see the ulnar midline nail bed. Then you come more on the, then you go on the radial side and then come on the ulnar side where you see this particular lesion. That's the DIP joint. So it is 7 millimeter distal to it. And the lesion is vascular. So when you see it in the short axis here on the ulnar side of the nail bed, this is the vascular lesion here, and it's very painful. So that's the glomus tumor. And thanks to Dr. Parag for sending me this operative images where the findings were confirmed that it was a glomus. Then last two cases where ultrasound is very useful, apart from showing the flexor and extensor tendon apparatus that yes, they are present or absent, we also do, with a 20 megahertz probe, we see for the circulation in the hand, and which helps the surgeon to plan the procedure about separating the syndactyles. For example, these are the dominant vessels coming from the superficial palmar arch from the ulnar artery. The radial artery is nicely patent and giving supply to the thumb. So this is a new thing which we are doing for a long time, and it really helps. This was one of the first cases which I had attempted after Dr. Warrior told me to see if we can see the microcirculation, and this was what we had drawn and we had planned, and this is what the amazing surgery which he did, and the patient was able to do a good functional movement. Last but not the least, the last one case which I want to show you all is that whenever there are humerus fractures and plating is done, and sometimes these fractures are not united properly, you guys plan for revision surgeries, and that is when we can pitch in by help you trace the radial nerve over, which is safe and lying over the plate, and kind of do a point marking so that while you're doing the surgery, you can plan that the radial nerve is safe and does not get injured. So summarizing, ultrasound can give so much information and even much more than other radiological modalities when we need to see soft tissue structures with dynamic evaluation. With correct equipment and with the right frequency probe, like what I'm using, the small footprint 20 megahertz probe, and knowing the anatomy, an accurate probe map like a Google map can be given to the surgeon, which really works wonders. Honestly, have learned a lot from operative feedbacks. So when I'm doing a scan with the thought process of a surgeon, it makes my work so motivating, and it always helps in giving a lot of information. Thank you for your patience.
Thanks, Ashwin. That was really a wonderful peep into your world. And I am handicapped when you are not around and when you don't give me that information. I've become so dependent on getting that information from sonologists, and now there are other sonologists also who are doing equivalent work. The thing is, you need to be on the same page that the sonologist needs to know exactly what you want and why you want that, so that he can help you in making your decisions. Now, once we got this going, and this is the things that he can show you are just amazing, we wanted to take the next step. And to take that next step, we again went and got trained with him, and we started using the ultrasound machine intraoperatively. And to tell us a little about that, I'm going to share screen and play out Dr. Nikita Shetty's presentation. She unfortunately had to, she had to fortunately go home to attend her brother's wedding, and I will play the video on her behalf.
We can't hear her, Sudhir.
Pardon?
There's no sound.
Oh, sorry.
Maybe you need to optimize for the video clip. Agnivesh, what do you think? Optimize for screen sharing or something like that?
Is it any better? No?
No, no.
Oh.
Stop share and reshare with Agnivesh. Are you there?
Or if Hemant can share and see whether there's something.
Yeah, sir, if I may suggest what Swapnil had told me in the morning, you just minimize the video, sir. Stop share and minimize the video.
Yeah.
Now share again, and then click on the video again.
And when you're seeing that screen share, I think there'll be a button which says optimize for screen sharing, optimize sound.
Do you want me to try from this end?
Yeah, if you can, because I seem to have lost that presentation. I'll open it again, but you try it once.
A very good morning, everyone.
Yes.
Dr. Ashwin has very nicely established the superiority of this investigation, especially because of its possibility for dynamic imaging. However, the reliability and accuracy of this investigation is highly interpreter dependent, and therefore a proper training is very essential. It is very interesting
we
when
are not
you
seeing
can
it
correlate your
full screen.
intra
We are just
findings the operative investigations. And this is how we got very keen in getting trained under the supervision of Dr. Ashwin Lavande.
Yes,
with the growing popularity of
manager.
USG guided regional anesthesia these days, a portable USG machine is very easily accessible in most of the operating theatre complexes. This machine, and both me and Dr.
No, we need it full screen.
Yeah. Hemant, can you just pause?
Operative ultrasounds are not new. They have been
Hemant, can you just pause it?
For the past 10 to 12 years in GI surgeries and in neurosurgery. But hand surgery.
Have I paused it?
That's better. Now the screen is full. Maybe you can restart now.
Where sometimes, despite an extensive preoperative investigation and examination,
no, you're okay.
Intraoperatively, we are in a dilemma where these studies, like an intraoperative ultrasound study, can come to our rescue. For example, here where a 45-year-old male presented to us with a chronic volar plate injury and an uncorrectable deformity, hyperextension deformity of the PIP joint. We went in and did an MRI, which showed that there was an avulsion of the volar plate and there were joint adhesions. Therefore, we opened it volarly, performed an arthrolysis and released the volar plate, despite which we could not achieve the desirable results. A preoperative USG was done for this patient, but at the time, because there was no flexion at the PIP joint, a dynamic imaging was not possible. we went in and did an intraoperative ultrasound, which showed adhesions of the lateral band. So at this point, we decided to open the joint dorsally and performed a lateral band adhesiolysis. This wouldn't be the case if we were not sure about this. I mean, opening the joint volarly and dorsally, we would have been a little apprehensive because of the chances of excessive swelling, pain, and stiffness. But because of what this intraoperative USG showed, we got this confidence in opening the joint dorsally, and this was our last resort. And then we went on to reattach the volar plate with a suture anchor. On post-op day 4, the patient had fairly good flexion at the joint, and at 4 months, he regained good functional movements at the PIP joint. This patient presented to us with a glass injury on the medial side of the elbow, which was initially treated with skin suturing at some other facility. On getting the USG, we found that the ulnar nerve was transected, which was completely missed in the first examination where he went to get the skin sutured. But the ultrasound did not actually give a clear picture of where the two ends of the cut nerve were. So we performed an intraoperative ultrasound and found that both these ends were on the most proximal part of the scar. So now, if not for this study, we would have opened the entire scar, did a extensive exploration to find the ends of the ulnar nerve. Because of this study, we could limit our incision, therefore avoiding post-operative complications like pain, and most importantly, the possibility of post-surgical subluxation of the ulnar nerve. This 10-year-old boy presented with an open injury on the palm. Because this patient was young and in a lot of discomfort, he was not very compliant for a sonography in the outpatient department. And also because it was an open wound, we had concerns about wound sterility. Therefore, we took the patient into the OT, and under anesthesia, we performed a sonography, which showed that only the FDP was injured at zone 2. So we went on with a limited incision because we knew where the two ends of the FTP were, and we performed a focused exploration. And this way we could avoid fibrosis and adhesions of the tendon post-operatively, which allows smooth gliding of the tendons. So now if we did not have this intraoperative USG, we would have opened we would have taken an incision along the entire finger to find which tendon was cut and where these cut ends were. So basically, this investigation helped us in keeping our dissection very focused. This is the boy at 2 years with good FTP function. Now, sterility is definitely a concern when you're performing a USG intraoperatively. A simple way to solve this is by covering the probe and the cord with a commonly available camera cover in the operation theatre. Here is a 3-week-old open injury of the DIP joint, which was managed elsewhere with serial dressings. When the patient presented to us, he had severe pain and stiffness in the PIP joint. On getting an X-ray done, we saw that there was a chronic DIP joint dislocation which was missed. And because this was irreducible and chronic, there was a possibility of the FTP being interposed in the joint. Therefore, we performed a sonography and saw that there was no FTP interposition, and then went on to reduce the joint closed by using a K-wire in the terminal phalanx to joystick the terminal phalanx back into place and fix this with a temporary K-wire. Now, this patient presented just an hour after his injury with an X-ray from outside that showed a fracture of the proximal phalanx of the middle finger. We took up the patient the next day for surgery, and on table, after giving him regional anesthesia, we found that there was extensive bruising on the volar side of the thumb, which is very common with Jersey thumbs. Because this patient was already under anesthesia, we could not perform an active dynamic test. Therefore, we performed a passive dynamics test and found that the FPL was in fact intact and was attached to the terminal phalanx. And the flake of bone that was fractured was lying proximal to the attachment of the FPL. Therefore, we decided to conserve this, and the patient had good FPL function on follow-up. So here is a lady with chronic osteomyelitis following a failed wrist fusion. She had a non-healing sinus in spite of multiple explorations, and the X-ray was not able to explain anything exactly because of all the procedures that she had undergone. Therefore, we performed an intraoperative ultrasound and found a small piece of sequestrum lying at the screw entry site. We went in with a limited incision, took out the sequestrum, and the sinus went on to heal very well, and the patient has had no complaints since. Now, distal radius platings have become very common these days, and the complications associated with it have also gone up. So, for example, in this rim fracture, we use 2 K-wires to hold the small distal fragments of these fractures, bend the wire, and paste a plate on top of it. Now, after this, because the K-wires are crossing the watershed line, we were concerned about impingement of the flexors on the hardware. Therefore, we performed a sonography and found that the flexors were not at risk because of the implant. Similarly, this can be used to identify long offending screws at various sites. For example, here, where a long screw on the dorsum of the radius is seen impinging the extensors. Now, displaced mallet fractures can be healed conservatively if properly splinted in extension. But in this 3-week-old mallet fracture, we found that there was no reduction in gap even on hyperextension of the joint. Therefore, we decided to go in dorsally. We cleared out all the intervening scar tissue and reattached the tendon with a suture anchor. Now, intraoperative ultrasounds can also be used to map out neurovascular structures around tumors. So what this does is it gives us some extra confidence while we are dissecting around the tumor, because we know exactly where these important structures are lying. So basically, intraoperative ultrasound has helped us in reinforcing our confidence in making those strategical decisions on table. There were no infections or any untoward events so far, and it added only 4 to 10 minutes to the intraoperative time. Now, there are other places where this investigation can be used, like to trace out the radial nerve and radial nerve palsies, either post-trauma in humerus fractures or post-surgery in humerus platings or nailings. We can look at adequacy of flows across vascular structures. We can map out neurovascular structures around tumors and around Dupuytren's cords, and also in difficult implant removal situations. Now, there are definitely limitations to this procedure. 1, you have to register yourself under the PCPNDT Act. 2, there is definitely a learning curve, and it is highly interpreter dependent. But at the same time, it is very cost effective. It is easily available in most operation theaters. There are no radiation hazards, and the most important of all, dynamic imaging is possible. Done properly and with a clear understanding of the anatomy, an intraoperative ultrasound can be used to boost our confidence and to reassure us when we are making very difficult decisions intraoperatively. And this can help in, this can be like a game changer in such situations to give a very good outcome to the patients. Thank you.
Yeah, I think we are a little short of time. Are there any questions, Rujuta?
Not yet from YouTube.
Okay.
They were having the
So maybe
seeing the movie, so I think probably they'll come in later. But maybe you can just make a couple of points, and then we move on to the hand transplant.
I can just comment that after I have interacted with Ashwin, I have stopped doing MRI. Instead of sending patients for MRI,
absolutely.
Yes, I mean, I would think so too, because all the images have been very, very clear and absolutely precise. So I think what the audience really needs to remember is that there is a huge variety of applications that the ultrasound can have. And I thank Sudhir for really showing us that how it can make a difference in intraop also. So that's something really new that we picked up today.
Right. Hemant, you want to take on the next session? Thanks, Ashwin, for staying awake with us through the meeting. It's been really wonderful. The journey is really wonderful, and I hope there's much more to come.
So there you are doing well. You can continue.
Thank you for everything, sir, and thank you all the faculties. I
Oh.
think I'm there and attending the orthopedic conference wonderfully, and I'm thoroughly enjoying how each person is having different kinds of treatment opinions and views on a particular case. Enjoying it. Thank you.
Thanks a lot. We'll go on to the last part, and I think the biggest game changer of all. It's been something that we've all wanted to do. We've all thought at some time that I must do this because this is where I get, I see that a lot of patients will benefit from. None of us ever seriously took anything about this any further than just discussing it amongst ourselves or sometimes with the hospital staff. But the two people who are going to take us through the next session have been working at it in such a dedicated manner that hand transplants have become a reality. I'd like to introduce Dr. Nilesh Sadbhai, an absolutely wonderful, focused plastic surgeon with whom we've been associated for many years at the Ethicon Institute, and who did the first hand transplant in Mumbai. And also Dr. Vinita Puri, who's the head of plastic surgery in KEM, who's been also parallelly working. And I remember going for the first hand transplant exposure that we had in KEM, was it, Vinita, long ago? Someone was visiting and we had one. I can't even remember who it was, but it was fantastic that we.
Yeah, that was Professor Brian back, and that was probably in 2008 or 7.
Absolutely. It just shook us up a little and said we must wake up and do something about it. Well, thank you both for doing so much. And I hand it over now to Nilesh to take us through the journey of a hand transplant. The reason we are putting this here is not because of anything. I mean, we know that hand transplants are being done. We read it in the newspapers. We have understood what it is, etc. But there are so many patients who come to the OPD and have so many questions that most of us have not too many good or intelligent answers. And to take us through all of this and tell us those patients who are likely to benefit from this rather than crowd up their OPDs, we want to know whom should we refer to you and what are the implications of a hand transplant. Nilesh.
Thank you, sir. I begin with sharing my screen. Fine. Is it visible now?
Yes.
Yeah, yeah, sure. A very good morning to all of you. I am Nilesh Sadbhai, and I will be talking on hand transplants. Warrior sir aptly named it as a giant step realized, and we'll discuss the process of how it began and what stage we have reached today. At the outset, I would like to thank Dr. Warrior, Dr. Patankar, Dr. Rujita Mehta, and the entire BOS team for providing me this opportunity to deliver this masterclass. And the theme for today, as it is, practice changing ideas or the game changing. I believe that hand transplant indeed has been the most biggest game changer in hand surgery. To begin with, when we look at these images, we know that how the hand has evolved, how the dynamics of the thumb have changed, which has made the hand an excellent device and has placed us on the top of the food chain. So we all know the importance of the hand function. It is a masterpiece of human evolution. And most importantly, it is extremely difficult to duplicate the hand function even in today's advanced computer era. So if we look at the sensory and motor homunculi, we know that the hands have a very wide representation in the brain, and that again makes the salvage and reconstruction of hands extremely important. Before 1962, there were no options for an hand amputation. So the patients had to lose their hands forever. So it was a very sad situation. However, the first replant was performed in 1962 for a shoulder lever amputation, and this really changed the situation in the hand amputations. So I believe that the first attempt is always the best. Hence, all amputations should be replanted in the best possible way, or at least an attempt should be made. Unfortunately, there are situations where the part may not be replantable or the replant may fail, which again makes the patient susceptible to live with a disability for life. Traditionally, they have been referred to use hand prosthesis, but we'll discuss the utilities and the usefulness of the prosthesis in the next few slides. If there's a partial amputation of one or more digits, we have some more options of reconstruction without going ahead for transplantation. We can perform single or multiple toe transfers, or we could perform an osteoplastic reconstruction in order to replace the missing digit. When the amputation happens at the level of the wrist or proximal to it, then we have really very few options. Traditionally, the Krukenberg's procedure has been described, which creates a sort of forceps by splitting the radius and the ulna. But this has very limited use, and this is a very rarely performed procedure. We know the gravity of this situation. We have too many amputees. These are a huge burden on our society and on the finances of any family, because they have lost their ability to live their life to full potential. They have lost their jobs most of the times. They are depressed. They are dependent on their family members for majority of their activities, and they are living a very compromised life. So indeed, it was extremely essential to find a reasonable and a suitable solution for these unfortunate amputees. We can only imagine the plight of these amputees by considering all the disabilities that they would be facing in their day-to-day life. And unfortunately, it has been noted that all these amputees, or majority of them, have tried using an artificial hand or prosthesis, but they have really found that it is not of much use, or it is a futile process. There have been very advanced prostheses available in the market today, ranging to a very significant cost as well. The technology claimed is extremely superior and fascinating, but unfortunately, they have still not reached the standard or to meet the demands in the day-to-day situation. The problems with the prosthesis majority are that they are insensate. They cannot be used in water. They are heavy most of the times. They can cause stump-related problems. They have a poor or inadequate function. They are exorbitantly costly, and the cost is not one time. It is a recurring expense. They do need repair and refurbishment after a couple of years. And all these factors lead to non-compliance. The amputees often give up using the prosthesis, and they are better off without the prosthesis rather than with it. So this is an extremely important thought which impressed me. The quality of life is more important than life itself. Indeed, in today's era where people are conscious about their looks, their personalities, and life is looked upon in a much different angle, it is important that people are independent. They don't lose their dignity and self-respect. They are able to take care of themselves without being dependent on anybody else. And all this should be achievable within a reasonable frame of safety and financial constraints. I believe that hand transplant is indeed the best reconstructive option for most bilateral amputees and some selected unilateral amputees after proper assessment and analysis, which we will discuss in the next few slides. Recipient selection. Now, this slide, I believe, is the takeaway of my talk today. It is the most important factor which determines the successful outcome of a transplant or the success of a transplant program is the appropriate selection of the recipient. Now, as I said, majority of the bilateral amputees are in need of a transplant, and some select unilateral amputees also deserve a transplant. So what are the characteristics of an ideal recipient? He should be a motivated adult. He should be in good general health. He should be psychologically stable. This is one of the most important factors, because transplant is an extremely important responsibility for the doctor, for the patient, for the family, for the entire system, because it is a major change in the lives of the patient. They have to take care of the transplanted limb throughout their life. They have to take certain medications or immunosuppression throughout their life. They need to be repeatedly checking and following up with the concerned physicians in order to ensure that everything is going on well and there is no problem happening anywhere. But if you understand and accept these responsibilities as a part of your life, then you're definitely bound to get the maximum benefit of this procedure, and and it is possible that you could live a normal life like any others. These recipients should also have tried the prosthesis in order to know its disadvantages and limitations, so that they value the transplant. And technically speaking, yes, they should have a favorable mechanism of amputation. Naturally, a guillotine amputation leaves a better stump as compared to crush, avulsion injuries, or burns. And the level of amputation, if it is the distal the amputation, the better. The donor criteria, of course, we have been struggling to create awareness for organ donations and hand donations because it is extremely difficult to convince the families to donate an external organ. This resistance, however, is gradually being overcome due to the success stories that have come out and due to the inspiration that is generated among these potential donor families. Naturally, the workup and matching has to be extremely perfect. A blood group matching along with a HLA typing is extremely essential before we proceed with the transplant. And then because it is an external visible organ, we could expect that the donor and the recipient should be of a comparable age, of a similar skin tone, of a similar hair pattern or ethnicity, and that there are no identifying marks. But all these criteria are quite fluid because there is a severe dearth of donors. So we are not really being very strict on these criteria when it comes to donations, because we need to accept the donations if there is any. Like any other transplant, the exclusion criteria are infective diseases, HIV, HBsAg, HCV, of course, encephalitis, malignancies, paralysis, neuropathies of any kind. It could be infectious or related to systemic disease, toxic neuropathies, rheumatoid arthritis or osteoarthritis with deformities, uncontrolled hypertension, significant trauma to the limb itself. All these are the exclusion criteria. Rejection, yes, rejection is an important aspect of transplants because however perfect the matching between the donor and the recipient is, there is always a potential of rejection. This reaction is more immunologically active in the first year after the transplant. It does tend to settle down with time. Chronic rejection also is possible due to the changes that happen at the vascularity and the microcirculatory level. And to monitor these rejections, we have to perform protocol biopsies and monitor these limbs at regular intervals in order to modify the medications, if any. Now, the better part is that because the hands are visible, you can pick up these changes quite early and take the necessary action in order to prevent it from turning into a major rejection. So, hand transplant involves an extreme challenge in terms of logistics. It needs a large team. A lot of specialties are involved, including the microvascular surgeons, hand surgeons, orthopedic surgeons, anesthetists, the immunologists, the intensive care, the nursing and the supporting staff. So all these staffs need to be activated in a very short amount of time. And plus the donations are never really at the right times. So they are typically in odd hours, in odd places. And then the retrieval of these organs have to be coordinated with all the other organs such as liver, kidney, heart, lung, pancreas, intestines. So it is a major logistical exercise. So we are actually totally involved and associated with it 48 hours prior to the transplant when all these things are happening. So typically it demands a multidisciplinary tertiary care setup which is capable of conducting the procedure and more importantly the aftercare. There are certain moral and ethical issues in these transplants because like any other organ transplants, hand transplants are not life-saving transplants. These are life-enhancing procedures which are being performed to improve the quality of life of the individuals in order to make him independent. So the decision has to be extremely thought after, and all the eventualities have to be explained in details. But yes, to your surprise, convincing a recipient or explaining a recipient has never been an issue, because they have seen the reality, they have faced the difficulties, and a sensible person is definitely able to understand these things and make the necessary changes in order to be able to get his own hands. Yes, they are on lifelong immunosuppression. There is a questionable doubt that it could affect life expectancy in the long term because of the potential risk factors associated with immunosuppression. But yes, the good thing is the first successful transplant, which Dr. Brian Beck had performed in Louisville, Kentucky, is now 24 years old post-transplant, and the person is hale and hearty, he's doing well. So good care is extremely important for a good outcome. And in fact, it was Dr. Brian Beck's talk in KM in 2007, when I was a first year plastic surgery resident, which actually really inspired me and exposed me to the world of transplants. And then we worked on it, and we've reached this stage today. So the unique features of transplants are that because the hands, as we discussed, have a cortical representation in the brain. So when the hands are lost, the areas in the cortices which represent the hands tends to shrink, because no activity is happening at the peripheral level. And then when the transplant is done again, the new hands start functioning as the nerves recover, and then the brain has to adjust to the new situations and understand and accept these hands. So it is exciting even on the cortical level to trace these findings, which can be assessed on a functional MRI, and it is actually an interesting study. Regarding the donors, there are issues because this is a visible or a mutilating organ donation, so there is resistance to it. There are several cultural, religious, and ethnic hurdles for a donation of an external organ, which we are trying to overcome. Considering the functional outcomes, yes, worldwide, majority of the programs worldwide have reported excellent function outcomes after hand transplants in terms of prehensile function, grip strength, motor power, patient acceptance, quality of life parameters, resumption of work, and psychosocial well-being. So it is indeed a very gratifying surgery when planned and executed properly. So I move on to our journey, which began in December 2016 when we got the license for the hand transplants after KEM Hospital in Mumbai. And we were in the process of creating awareness, registering the potential recipients, and creating awareness for hand donations. This was our first case, 23-year-old girl, female, quite a popular name and face in Mumbai, because she lost her hands in a train accident at Ghatkopar, which was a gap trap accident, and it created a huge social outcry, which led to the rise in the platform levels. So she was a college student at that time. She lived with the amputation for 6 years. She was totally dependent on her mother. She was socially withdrawn, quite depressed to some extent, because she was dependent on her mother for practically every activity. Unfortunately, her father also had a renal failure, and he passed away before her transplant. So this was the profile. We had a detailed workup done beforehand in order to assess the limbs, assess all the structures, the muscle and the vascular neural components in the limb. We had performed a detailed immunological workup in order to ensure that there is the match with the donor is perfect. So as I said, it is a logistical challenge because we need 4 teams working simultaneously on 4 different stations. 2 teams preparing the recipient hands, 2 teams preparing the donor hands. These are some images from the surgery about the recipient preparation. The stumps are opened up. Often the structures in the stumps are quite badly scarred due to the previous injuries and repeated surgeries. There is a lot of scarring. Some structures are missing. Some muscles or tendons could be really very short and may not have adequate excursion. We also need to assess the neuromas and the levels. The main problem that is often felt is the superficial veins, because those are missing. As the stumps are scarred, many times they are skin grafted. So the recipient preparation is always extremely challenging, and we have always landed up with surprises. The donor hand is prepared at the same time. This is a race against time. So the ischemia time has to be as low as possible. Worldwide, the acceptable time has been around 6 to 8 hours. And so the retrieval of the donor hands and the preparation of the recipient and then the coordination has to be really perfect so that we are able to reperfuse the limbs in time. These are images of the prepared donor hand. As we did it at a proximal forearm level, in this we did not do individual tendon repairs, but we did en masse repairs of the common flexors and the common extensors, along with all the other major structures identified and tagged. It is important that we tag all these structures so that the repair becomes easier without any wastage on identifying them at each level. Now, fixing these hands, initially, I would appreciate the participation of my orthopedic colleagues, Dr. Sridhar Archik, Dr. Anup Khatri, Dr. Neil Dhamnaskar, Dr. Manoj Jain, and all others who helped us with these challenging tasks. We really underestimated the challenges that we would face during the bony fixations because of the altered anatomy and the altered dynamics. The fixations of these transplants are much different from forearm plating or from fracture fixations, and they do need special considerations, which of course our team has now gained with experience. We did vascular anastomosis. The trick is to perform one artery and one vein in order to perfuse the limb, let the venous return begin so that the blood loss is limited, and do as many veins as you get. So in this case, we had done 2 vena commitants along with 3 to 4 veins on both the sides in order to ensure adequate venous drainage from the limb and to prevent the edema and postoperative scarring and complications. The nerve and the muscle repair were done to the respective structures. These are the superficial veins and nerves repaired. And this is at the end of the procedure. We took 16 hours for the first procedure, so it leads to a lot of muscle edema. Also at the proximal forearm level, there is an overlap of the recipient and the donor muscles. So it does lead to a bulky forearm to begin with. But as there is some muscle atrophy in the post-op period, this bulk does settle down. So this news was widely published and it did create a very significant awareness between both recipients and donors. She is on immunosuppressive regimen that we followed is thymoglobulin on induction and 3 drug therapy for life. So MMF, tacrolimus, and prednisolone are the 3 medications which these patients in today's day have to take for life. The tacrolimus levels are targeted and maintained at 10 to 12 nanograms per deciliter. The post-op recovery, the good thing is that most of these patients are young, so they don't have many comorbidities and they recover uneventfully. But yes, we do need to monitor them to ensure the impact of these immunosuppressive medications on the cardiac and the renal function. So she recovered really well. These videos will show the gradual recovery that began almost 3 to 3.5 months following the transplant, where we could see some flicker of movements or extrinsic muscles working. I'm sorry. Yeah, so these movements gradually progressed. It was really exciting. It is like seeing a small baby take footsteps and walk. And gradually, we need good muscle stimulation. We need good focus exercises. We need splintage to maintain the positions, avoid contractures. Using the mobile phone has become an important part of our lives, and these patients actually become extremely independent and happy when they are able to use their phones. So she started using the phones roughly 4 months, 4.5 months after the surgery. Assessment at 1 year of age showed that there was good recovery in the extrinsic flexors of the wrist and the fingers. The intrinsics, however, are recovering and they would continue to recover in the next few months. And I'm sure that she will have a better function in the days to come. At 14 months, this was the function of the wrist and the long flexors of the fingers and the thumb. She does have some clawing in the fingers. Of course, ulnar nerve we know is quite notorious for late recoveries, which may require some corrective procedures if needed. Thumb opposition is improving day by day. She is now able to oppose the thumb to a reasonable extent. So we have been monitoring her for rejection, and it has been a really pleasant surprise that we did not encounter any single episode of rejection in this case till date, which is almost 18 months from the surgery now. She had a very mild urinary infection at 6 months, which was treated with antibiotics. She did have COVID infection at 8 months, which was treated with home isolation. The DASH score showed a very significant improvement of 20 points in her day-to-day activities and function. The hand transplant scoring system is another modality to assess these patients, and she has shown good recovery till date on all these parameters. And of course, with the intrinsic recoveries, she will turn from good to excellent with time. So the milestones she has achieved is that she can now take a bath, she can take care of her own hygiene, she can open a water bottle, drink water, lift weights, carry bag, use the mobile phone. She travels independently and types on the keyboard. She's also trying to learn to write with a pen. And importantly, she's now employed in our own hospital as a coordinator. And that has made a huge impact to her morale and to her family to see her work independently. And it has also made a huge impact on the potential recipients. She did perform the Ganpati Aarti this year, which was her dream, which she had mentioned before going in for the surgery. This is the second case. This was a quadruple amputee who lost all 4 limbs after an electrocution. He underwent transplant 4 months back. The right side was at a supracondylar level and the left at the proximal forearm level. He's now in the early stages of his recovery. This was the third patient who underwent again a quadruple amputee. Both the amputations were trans elbow level. He underwent bilateral supracondylar transplants. He is an extremely motivated individual and is recovering quite satisfactorily. This is a recent case we did 1.5 months back, a bilateral amputee, again, a proximal forearm, a mother of 3 children, extremely strong woman, desperate to get back to her daily activities and take care of her family and children. She underwent bilateral transplants, again, the right at the proximal forearm and the left supracondylar level. She is expected to begin her recovery in the next few weeks. And this was a recent transplant we did in a boy with a mid forearm amputation on the left side and a partial hand amputation on the right side. Now he had an intact thumb and little finger with the index, middle, and the ring fingers missing. Now, in a normal situation, if a person presents with isolated injury or a partial amputation, he is not a candidate for transplants. Because we have better reconstructive options, or even without reconstruction, with a thumb and little finger, he can perform reasonably well. But he needed a transplant for his left hand. He did have limitations, as the scars on this hand were quite stiff and painful at places, and he was not able to optimally use the right hand as well. So we performed the transplant for him on the left hand at a mid forearm level, and on the right hand a partial hand transplant involving only the index, middle, and the ring fingers. So he is again a motivated young boy who is the only earning member of his family, and I'm sure he's going to recover well and work hard to earn his bread. So a transplant is the ultimate legacy we can leave, and it is the greatest gift of community service we can give. So I think it is extremely important for all of us to be aware of the beneficial effects of transplants and to create the necessary awareness for it. This, in a nutshell, are the 5 patients we just discussed, and I'm sure it is a ray of hope for many who are appropriately selected. I would like to thank my team. It is a huge mammoth effort, a large team behind this who has contributed at every level in order to achieve successful outcomes in all these cases. This is a special moment. As we discussed, the transplants are visible. So you can see the hands actually working on somebody else's body. So the parents of Monica's donors flew down to Mumbai in order to meet Monica, as to see, feel, and touch the hands of their son. And this was really a very special moment of transplant bonding between the two families. Thank you so much.
Thank you, Nilesh. That was absolutely, I'm just choked with emotions. Absolutely fantastic. And that journey must have been really, really fabulous to go through, planning it and executing it, bringing in the donor at the right time, having your team. It's a huge team. Having them all ready at a time when you haven't planned anything. Suddenly you have the hands and you've got to go ahead and do 16 hours of surgery with so much of infrastructural support. It's mind-boggling what you pulled off. I can imagine that happening in a private setup, but Vinita, doing that in a municipal hospital, having that dream and having pulled it off, that's something else. So, Vinita, we'd like to know about your journey through hand transplants.
Thank you, Sudhir. All right, so I'll share my screen directly. Right. Nilesh has made my job very easy because he has basically told everything about transplants. And I will, as Sudhir said, he basically gave me the mandate that I must speak about how we went through it and how we managed it in a public hospital. So basically, hand transplants in India, I don't know whether Nilesh mentioned it, but the first one happened in January of 2015 in Kochi. And there have been 6 institutes which have done transplants up to now. With AFMC Pune did do one in 2018, but that one was not successful then. And I'm sure they'll go ahead with surgeries now. How did we make it possible? So here is our patient, a young 21-year-old boy who after his 12th standard basically went to his brother's place somewhere in Faridabad, and just because they are poor, he thought he would earn money for some time, and he landed up working in a factory, and somebody started the machine, he didn't take his hands out, and he had an avulsion injury. So what are the requirements? To make it very simple, what are the requirements if you want to get a hand transplant license for your hospital? You need to apply to the Directorate of Health Services for registration. An inspection gets done. When patients come to you in the OPD, you evaluate them, register the patient with the ZTCC, and operate. When you get a call for donor, give post-op therapy, and voila, there's your patient. So this is telling this in a very, very simple manner. But it is not that easy. The whole application to DHS is a very huge form with the file becomes really fat. And so I guess in a corporate hospital, you have the HR department or someone from the administration who runs around and gets everything from the concerned consultants, the nurses and technicians, whatever is needed. But in our case, in a public hospital, that's not true. So it was basically one from our surgical team. So one of our assistant professors did the job. It took over 2 months probably to get everybody's certificates and get that file in place. I didn't want to move with the file without making sure that everything is absolutely perfect, because once you submit it to DHS and you pay their charges, I did not want any rejection at that time. So it took us some time to get everything ready. You also have an issue about payment of charges in places, because a public hospital doesn't really have any system in place where you can say that the hospital is going to pay. But in our department, because of the workshops we do at times and at regular intervals, there is something called a department development fund. So if something is needed from the department, we are able to use funds from that. That is how we manage the fees which was to be paid to DHS. Inspection is not really a problem, being from a very large multi-speciality university hospital. KEM has all specialties at hand. We are also exceedingly well equipped, so we did not really have a problem in inspection, and that was a smooth affair. In terms of license, as Nilesh mentioned, we received our license earlier. We received our first license we received in May of 2016. Now, when DHS gives the license, it is only for a period of 5 years. So in this 5 years, we did have 2 patients registered. But unluckily, and we also received calls for the patient, but there was ABO cross match. There were compatibility issues, and they were not of the right blood group. The other thing that happened is that when COVID struck our patient, so one of our patients basically backed out. The other patient, after having waited patiently for so many months, he used to come to us every 3 months and make sure that he presented himself to the OPD and reminded us that he was waiting there in line as a registered person. When COVID struck, and because he was very poor, he was one of those people who had the reverse migration. He went off to the village and never really returned and did not get a hand. In May of 2021, we renewed our license, and this patient of ours actually came to us and presented to us somewhere at the same time. So what are the challenges that we face with the patient when the patient comes to us in the OPD, and the challenges for registration of the patient with ZTCC? So I think one of the big issues that patients face in public hospitals is that the hospital itself is so huge that it sort of tires out the patient, and there is a perpetual feeling of being overwhelmed. There is also a lack of confidence in the system, because they feel that if they had more money, they would surely have gone to a private hospital. So though they have confidence in the abilities of the doctors, there is lack of confidence in the system. And I also realize and I accept the fact that any patient who comes to us is coming to us as a second choice. Given the choice, if they, or at least they feel, every poor person feels that if they had the money, they would go to a private hospital and not really come to a public hospital. All the patients who present to us also are either uneducated or they have uneducated relatives, and the explanation to them is that much more laborious and difficult, and we have to put in a lot of effort to make them understand about a transplant. Where finances are concerned, finances are needed for the patient, not just for the actual surgery and for the drugs, but also because patient needs to make an effort to live in the city. Once they are registered, they need to be around so that they can come down at short notice. And also after the transplant, they have to be around because therapy is needed. So if you look at a SOP, we have a very strict SOP all written down and ready. So zooming in, you see the pre-operative evaluation, and you have a huge list of investigations which need to be done from general point of view and also from limb specific point of view. And if you see the SOP, you'll see that there is a very large number of references. Now, in a place like KEM Hospital, where every department literally is a fiefdom, we don't have a single OT complex or a single OPD complex or a single place for investigations. The patients have to run around to each and every department to be able to get these jobs done. So to be able to make this easy for our patients and to be able to take some care about being overwhelmed, what we actually do is that we admit the patients who come in for requesting for a hand transplant, and after they have understood and they say that yes, we have understood everything and yes, we would like to go on the list, we get them admitted and we get the investigations done. The next thing is regarding technical capability building in a public hospital. So despite the fact that, of course, we are microvascular surgeons, our department has been doing successful replantations and revascularizations for the past 4 decades. We have very good therapy departments. We have a school of physiotherapy and occupational therapy. So they have advanced techniques and they do a great job. Our department, since we specifically do a lot of hand work, we have dedicated occupational therapists and we have our own occupational therapy, small subunit for plastic surgery. And all splints are also made in-house. So we have no dearth of equipment. In spite of that, to be able to get ready for hand transplant, as Sudhir mentioned, it's not easy. You have to get in all the people together, and it is more like a reality show, making sure that everything goes right at the right time. So we did a few cadaveric dissections, and this was again easier done for us because being a university hospital, we have an anatomy dissection hall. So here I can share a few photographs of our the first cadaveric dissection that we did for hand transplants. So now these are more, the ones that we did were more like mock transplants of the registered patient. So we recreated the amputations of what was there in the patient so that our dissection could be easy. This is the orthopedic team. So whenever we did the dissection, whenever we did the hand transplant mock-ups, the whole team was there, including the orthopedic surgeons and also the nurses who were supposed to be part of the transplant team. This is a 2016 one that we did. It's a very long time back. This is the whole team that operated that day for the whole day, including the orthopedic surgeons. The last one that we did was in March of 2020, literally just 7 to 8 days before the lockdown, and we had called Mohit as faculty in this. And this we did like an official workshop under the umbrella of ROTO, that is the Regional Organ Tissue Transplant Organization, which is situated inside KEM. So the office of ROTO is basically inside KEM. So here you see us doing the surgery, and this is the whole team. Again, this included the orthopedic surgeons and us and our nurses. So what I had done is that I also let us say that I chose some nurses who were really good from our theaters. So even there were one or two who were moved to other theaters, but whenever a transplant mock-up was done, they joined us. And finally, when we did the surgery, it was the same nurses who came in at odd hours to be able to assist us in the surgery. Again, to help coordinate between all the team members, we created a WhatsApp group so that immediately people could be called upon when needed. With respect to financial matters, it is a difficult job in a public hospital, because when the donation is inside the city, there's no problem. For example, the case that we did, the donation came from inside the city because finances are needed to travel and bring back the donated limbs. As of now, I have not been able to come to any good conclusion as to how we would be able to take care of the finances which are needed to fly down to another city, bring the limbs back, and do everything on time. So I guess that is one challenge which yet needs to be met. There are also quite a few investigations which are essential, which need to be done from outside. Now, in our case, when we called the patient in the middle of the night and we asked him to come down, he had only his father with him in the city. Father who though he wanted the job done on his son, was not very amiable with respect to really getting things done from outside. And though when we had counseled them, they had said that yes, they had kept some money aside other than the one which had been put for him in the poor box fund, and that would take care of all the outside stuff, but it didn't really happen. So as a department, we put up all the funds, and one of my residents went to the Hinduja to get the cross matching done. Another one went to Tata to get the blood irradiated. So the first few packets of blood we paid for, but later, after we informed Tata that was the issue, the Tata hospital made it all free of charge, and we were able to get irradiated blood for our patient without any cost. Now, tacrolimus levels and a few other tests needed to be done in outside lab. At that time, the lab person also helped us out, and he took the blood, he got it done, and we were able to reimburse him later. Finances for these patients are put in something called a poor box charity fund, and in our case, our patient was from Madhya Pradesh. So the Madhya Pradesh Chief Minister's Fund actually transferred funds to KEM. For that, I had to speak to the district collector of Tikkamgarh, a small place called Tikkamgarh, about 2-3 times before we managed to get the money transferred. I also managed to raise funds through some personal donations for this patient. From the physician point of view, our nephrology department has been helping out and has been taking care of all the transplant patients in KEM, which are for kidney. So he made sure that as soon as the call came in, we were given a dedicated nephrologist for our patient, and that nephrologist has been our one point of contact throughout, even to date. From the transplant ICU point of view, we were to use the nephrology ICU, but that went under repair. But luckily for us, there is also a liver transplant program, which is there in KEM. So we use the transplant ICU there for the post-operative care. From pathology and dermatopathology point of view, we had 2 dedicated pathologists. We had a lot of multi-speciality meetings prior. Once we had received our license, and these pathologists also were in touch with the Amrita team to be able to understand the pathological changes that happened and when the biopsies were given. From administration point of view, our administration was very helpful. And once we moved the patient to a step-down unit in a ward, which we created by moving out 2-3 beds, and we created a kind of like slum style, we created a area in our own ward for his step-down. Our administration provided us with a dedicated nurse and a dedicated class 4 worker only for this just one patient. And this was provided to us for almost 4 to 5 weeks in all 3 shifts. For post-op management, in spite of the patient being in the ICU, one of our plastic surgery residents sat with the patient round the clock in 8-hourly shifts. Dressings were done only by me or the other team leader. We had a dedicated team of therapists who visited the patient every day. The same therapist visited every day and even visited the patient on Sundays so that we would not have a break in therapy. Our therapists also had virtual meetings with therapy teams from hand transplant centers from other places across the world. Throughout this tough phase, we also kept his morale high. And I remember tying a Rakhi to this patient, which was very close to his transplant. It was just probably 10 to 15 days. And I got the Rakhi autoclaved. Here you also see him attending our Dashera celebrations. I'll also share a few glimpses now of the patient's journey. This is the first counseling. This is the last counseling that we did on the day of surgery. The father sat with us and the boy. There was nobody else. He had absolutely no family support. It took almost 2 to 3 days before his brother could come down from the village, and then things became slightly easier. But in that, for the first 3 days, literally, we were his father, mother, brother, sister. I really don't know what, but our department basically came together to make sure that we got everything done for this patient. And at no time it was that just because the patient does not have relatives, things have not got done. My residents have gone all over the city to do whatever is needed for this patient. These are a few photographs of our theater. We have a nice, large, beautiful modular theater, as you see, which can take in the huge team. And we have 3 theaters in our complex. So while dissection was going on one of the limbs, we were able to use the theater besides to be able to do surgery and do the limb dissection. Here you can see now the limbs being put together. These are our residents, the backbone of our department, and they were there throughout, running around and doing everything that was needed for the patient while we were operating. Here's a team after surgery. Here's our team after surgery in the theater. This is a photograph of the patient in the ICU. And what you see here, I actually bought an air filter because I was worried about COVID, and I did not want that complicating matters in him. And you can see here a saturation of 100 in his transplanted limb. After he was settled and after we moved him, as you see, this is our makeshift step down area that we made for him in the ward. Our assistant municipal commissioner visited him and our dean, and we're happy to receive flowers from the patient. Here is the patient for the first time writing with his own hands. And these are a few activities. I have no idea why the videos are not running. Okay, fine. So he is able to do, it is now 5.5 months, and he is able to do all activities of daily living. He is very sincere about his therapy and makes all his efforts to do everything that is needed. He is able to eat food by himself now, and most happy to do that. KEM has, we have recently installed a memorial for organ donors, and this is him paying obeisance at the organ donors at the memorial. he was very touched, and because he knows that he is the recipient of a hand from an organ donor, so he was very eager to come down to this memorial and pay respects at the memorial. Here's a huge big team, and none of this is possible without the team being there. And this photograph includes our OT staff, that is the support staff from the operation theater, our residents, our nurses, our anesthetists, the orthopedic surgeons, the nephrologists. Everybody is there in this photograph. Thank you.
Mind-boggling, Vinita. This is really, really fantastic. And relation. I'm sure every one of us who's been able to attend this have taken so many lessons and understood the hardships that you've gone through to try and make this a reality. And it looks like it's the beginning of something very, very, very great that's going to change lives for many, many of these amputees. Thanks a ton. If there's any questions, any points of discussion, Rujuta?
Yeah, 2 questions from me to start off. How important is it to fix them in supination?
Ma'am, your answer, ma'am.
Is Nilesh taking it, or Vinita wants to take that? How important is it to fix these in supination?
Yes. So just like any replant, we normally tend to position the limbs in full supination with the palm facing the face. So that is the ideal position, which gives the appropriate positioning of the forearm bones with the interosseous spaces. And yes, that I believe is more. It gives a better range. Of course, in a transplant situation, when the amputee has lost some part of the bone. I mean, the stumps are really short. Many a times the stumps are unequal. The space between the radius and the ulna has collapsed. The interosseous space is really very tight, and plus there is a discrepancy in the bone size of the donor and the recipient. So achieving the perfect position of the bone for fixation along with complete pronosupination becomes very challenging. Now in Monica's case, though she underwent forearm plating at a proximal level, her right stump was really very short and scarred. So she does have a restricted pronosupination on the right side as compared to the left side, where the length is longer and she's able to move the limb better. So that has actually made her a left-handed person now, because she finds the left hand working better. But in order to achieve a better thing, I think the fixation in full supination is preferable.
Okay, and is it possible to do a derotation osteotomy later, or is that no in these patients?
No, technically it is possible. Of course, you do tend to avoid repeated procedures because they are heavily immunosuppressed to begin with, and also later you tend to avoid any sources of infection later by keeping the surgical procedures to the minimum. But yes, some corrective procedures can be done if they are going to be beneficial.
Rujuta, lots of corrective procedures may have to be done, as Nilesh says, and we just have to be careful about the little immune problem that one can have. But once we have crossed a year and a half, once you feel that you've had the best function that you can have with the therapy that you have given, and given all the time that it takes for the nerves to go through, after that we do have to look at some corrective surgeries that if it's needed to improve function.
Hemant, your reactions?
Yeah, no, overwhelmed. I'm completely overwhelmed with this. Too much, very good work, and too much of effort, I think, is being taken by both of these, and I wish them all the best. Can I ask Nilesh, what is is this the right platform to ask him the average cost of this procedure at private hospital?
Yes.
So that we can tell our patients.
Yes, sir. So considering the overall scenario of the patients undergoing a surgery for 16 hours with a ICU stay for 10 days to 2 weeks, followed by an hospital stay for another couple of weeks, with all the medications, investigations, we estimated that a transplant would cost between 22 to 25 lakhs. With a lifelong expenditure of immunosuppressive medications, which in today's day is close to 15,000 rupees per month. But considering the financial constraints, because majority of these patients have been from middle or lower middle class, none of our patients actually has been affording enough. But we have made efforts to raise funds for them on crowdfunding platforms from social help groups. And actually, the main focus of these services is to deliver the service and to establish the program. So profits making is not being considered at all. And actually, I'm thankful to the hospital management for being so open and considerate about this. And that is how the program is sustaining and standing today.
Thanks.
Pankaj, your reactions?
Yeah. I mean, it was overwhelming and absolutely worth every second that my ears were receiving this word. Just a simple question. During the time that the replantation became common, one of the things of focus was always preservation of the amputated part and the transport of the amputated part to the facility correctly, which was not happening before the replantations really became commonplace. Now that the hand transplant is a real possibility and perhaps many centers taking place, would there be certain change in the guidelines how we handle the amputations? Suppose I were to forced to do a forearm amputation for somebody as a transplant surgeon, would there be any suggestions that I should not be doing what I was doing before? For example, we were always taught pull the nerve, cut so that it retracts back inside and does not cause neuroma. Wouldn't that make a transplant little more difficult?
Yes, it does
Something,
make the transplant. It
yeah,
does
something
make
like
it
that.
difficult.
So yeah, so would there be certain guidelines that will now change for the various levels of amputation
I
that may be
think the
performed per
guidelines,
day?
yeah, I don't think that the guidelines will really change, except for this bit that we don't want the nerve to be pulled too tight, far, too much. But you would need to send the nerve back a little bit, otherwise we would be faced with the problem of neuromas. So whenever our patients have an avulsion injury, for example, Rahul, our patient had an avulsion injury, we did find huge neuromas inside and a little much all the way long in. Otherwise, I am not able to contemplate as to how the guideline for handling an amputation change.
The reason I ask is, suppose there was a distal forearm amputation. We were always taught to give an optimum length stump so that the fitting of the prosthesis is going to be better. Now, the need for a prosthesis and need for a transplant could actually be contradicting each other. You would want it as distal as possible for a transplant, and you would
So,
want perhaps a mid-forearm amputation for fitting of the prosthesis.
right. You're right. So it's really also very much more important for us to make sure that the muscle tendon unit remains long enough, because only then would you be able to use the forearm muscle. So if it goes mid forearm and you lose length of the muscle tendon unit, then you would not get an adequate amplitude if you're going to use the forearm muscles, or you would have to go higher like Nilesh did in Monica's case, where he has actually taken all the muscles from the donor, whereas in our case we have used the patient's muscles. So it does matter what is the length of the muscle tendon unit that is left behind.
Thank you.
One more thing is regarding the bony shortening. The shortening of the bones in order to close the stump primarily, that actually can complicate the situations in some cases, because we did encounter some patients who in which it could have been a proximal forearm amputation, but it was made trans elbow in order to close the stump, or a short mid-arm stump was shortened further in order to do a shoulder disarticulation. and they are now they've now totally lost probably the chance of being considered for a transplant.
So your suggestion would be to maintain that length using maybe a free flap or a resurfacing rather than shortening to try and primarily close.
Yes,
that's an important message for some of us who probably deal with crush injuries and things like that. Brilliant. Anil Bhatia, you're hiding, but if you want to quickly say something before I hand it over to, thank you very, very much. It's been just amazing. I think a lot of us wanted some of this information and to celebrate with both of you all. Thank you very much for patiently waiting till the end, because I just wanted the best to be there at the end. And thanks, Rujuta, and over to you.
Can I say something?
If I can just put in a
Yes,
word.
Ashwin. Sorry, Ashwin. Sorry.
Let Dr. Bhatia say first. Let him go.
Yeah.
The question of supination and pronation, I understand that fixation in supination is what is desirable, because that would give you easier to do the carpentry. But as we all know, the flexor pronator group is going to get functional later on. The biceps would be inserted on the supinator tubercle and would keep the forearm in supination consistently. Therefore, the use of the restored limb would be limited because of the persistent supination. And therefore, one should perhaps consider this in future, maybe to try and fix in a neutral position rather than full supination. I understand, I'm not a transplant surgeon, I'm not into transplants or microvascular surgery, but in brachioplexus surgery, this is a problem we always face, that the biceps, the unhindered action of the biceps keeps the forearm supinated, and then the patient needs to compensate with the shoulder in order to get the forearm into a functional space. Therefore, here we have the opportunity to do the derotation of the forearm to start with, and therefore a consideration for a fixation in neutral would be worthwhile.
Yes, sir.
Ashwin.
Yeah. First of all, really overwhelmed with whatever was shown by Dr. Nilesh and Dr. Vinita ma'am. Excellent work. Since last 2 years, I think Nilesh and me are doing some work on these amputated stumps. So before he does the transplant, we do an ultrasound. So basically, the blood flows, the arteries especially, till the exact end, what they are going, what are the branches, then the nerve stumps, the muscles or the tendons, whichever are present. So exactly, Nilesh, how does this help when I give this information about all the structures, all the musculoskeletal structures except the bone? How does it help in your surgery planning? I just wanted to know that.
No, so basically the information needed is very basic. We need the structure and to identify all the structures and the levels at which they are available. And it is just because of your fabulous reports that I send them to you, because I tend to get more information from them rather than an MRI.
So
thank you. So
yeah. Typically in the proximal amputations, some of the patients whom I had sent, typically with a scarred shoulder, or the vessels really not really appreciable in the MRI or in the angio. We do get some specific information about the collaterals and other final vessels on a good high definition ultrasound.
Yeah, Vinita was saying something.
Yeah, so actually, it's like Nilesh mentioned, it's basically for the higher ones. For example, I have a mid-arm who's waiting, but the vessel is lying in the axilla. And though you can palpate and you can hear it on our, the Doppler, the superficial Doppler which we use, I did the same. I go to our ultrasound department, we all congregate. We have a lot of these multi-meetings, which radiologists are exceedingly important for us. And that has helped us a good ultrasound gives us a huge amount of information. So I love getting that information from ultrasound, even though we see the MRIs. And I think as surgeons, I don't know about Nilesh, or I don't know about all of you, we are pathetic about understanding MRI, but ultrasound seems like a better, more closer to surgery, as though we are opening it and seeing. So it does give us good information.
I think once you start identifying structures on your own, it really helps.
Yeah.
And it becomes an amazing picture to watch.
True.
Yeah.
Thank you.
So this has been just truly fantastic. I think the whole master series was a master craftsmanship. I would say that Dr. Sudhir Warrior and Dr. Hemant Patankar have really put out the most well-crafted program. Right from, what a range, right from the smallest PIP joint, DIP joints, fractures, to the ultimate dream of hand transplants, which I think we only grew up idolizing that. So I think where there's a will, there's a way. And the whole program has been fantastic. The speakers have been truly amazing. What is very important and what stands out is that everybody is so deeply involved, in depth with whatever they are doing. They're passionate about it, they're dedicated, and they have a lot of practical tips to share for everyone. The compliments are just pouring in on the YouTube link, as I can see that. And there's a very good suggestion from someone saying, can you provide this case on PDF slides to show to our patients whenever needed? If so, please email to all of us. So I think I'll appeal this in the BOS EC, that some way of having a material handout or something should be made possible. So this has really translated from the computer to the bedside, as I can see that, and people are keen to take it up. So thank you once again, both conveners. Thank you all the faculty. Thank you all our guest faculty. And thank you to the wonderful audience who have stayed despite the hand series, the master series going on to almost 2 o'clock. So now I think we can safely say in our Bombay city, hum sab pe 4 haath hain. So lot of blessings from the Almighty. And thanks once again to everybody. Thank you.
Thank you, everyone.
Thank you.
Bye.
Yeah.